Taking just a minute. All right. It looks like we are live in the Facebook group. Let's take a minute to get set up here. Okay, great. Hopefully that's working. They shouldn't let Gen Xers in charge of the technology. That's all I'm saying. I need some millennials or younger on here to help me. Welcome, everyone. Thanks for joining us today. This is our, I guess, second annual patient summit, where we are going to tell you a little bit more about what we've been up to in the last year, but we'll recap last year as well. We have some folks that have joined us here on the Zoom today, and we also have our live streaming in our patient support group, which is the Preeclampsia, Eclampsia, and HELP Syndrome Survivors Global Support Network. This is a program and an event of endpreeclampsia.org, and we're so excited to have you all here today. We have a pretty long day ahead of us. I just want everyone to know that they can come and go as they are able to. This is being recorded, so we will have the recordings available for those who aren't available right now or who have to, leave throughout our summit today. We understand you're all over the world. Some of you may be in bed sleeping while we're recording this live. But we hope that you'll come back to it and listen in on the parts that are, particularly poignant for you, and learn from all of the people here today, all the work we've done, and share your insights and feedback with us as well. You're going to hear today a lot about patient engagement, particularly in research. How can we use our voices as survivors of hypertensive disorders of pregnancy to inform research, to engage and participate in research, so that the scientific community understands what we need, what we're hoping they will look into in research. We know this disease best because we have lived it in some way, or we have with us today a number of professionals who do research on these topics and care for people like you and me who've had a hypertensive disorder of pregnancy. So our full agenda today, we're going to be talking first about our PCORI, our Patient-Centered Outcomes Research Institute Engagement Award that we've been working on for the last 2 years. We're wrapping up here the end of this year of the second year of our 2-year award. And we are going to talk about the process, how that came to be, what this PCORI Engagement Award is about, and all of the work that the people on the screen here and the rest of you in our community have participated in. We have a board of patients and scientists who have worked on this project, as well as a number of our what we call ambassadors who participated in training and focus groups and surveys, who will be talking. Some of those folks will be talking to us later today about their experience. And we also are going to talk about what sort of research topics that you as our community have not only identified as being important to our community, but you also prioritize them through a survey that we sent out last year to tell us which of those topics is most important in order. So we're going to talk about all of those. And then we're going to talk about next steps with our work here. To get us started today, I'm going to share my screen theoretically, and I've got some slides. Now, we're going to try to make this as conversational as possible, and we're not going to try to slideshow you to death. However, I do think the slides will be helpful just when you're, logging in the middle of a session, you can kind of catch up where we happen to be at the moment. We have a break scheduled from 12 to 12:15 Eastern time, Eastern US time. And then we have a lunch break from 1 to 1:30 p.m. Eastern time, so half hour there. But again, please come and go as you are able. We are really glad that you are here. And if you're watching us in the live stream, post a chat. Let us know where you're watching from. Let us know any feedback you have as we're talking today. Anything you'd like to share with us, we would love to hear. Okay, let me get my million tabs sorted here. All right. Panelists, can you give me a nod if you can see the slide? Okay, great. We've got it going. So today like I mentioned, we're here to talk about our Patient-Centered Outcomes Research Institute Engagement Award. We're going to tell you a little bit more about that, but I want to give a preliminary thank you, a huge thank you to not only some of the people on the screen here today, but many, many in the background, some of who we will recognize a little bit later in our day today for creating this opportunity for our organization. Spearheading that is Doctors Katie Corcoran and Sydney Martinez, who are on screen today, who were the brains and the experience really in writing the application that allowed us to get the funding that we have received to do this. And then some of the other folks on the screen and others who are not necessarily here today on the panel who have really brought their expertise, their experience, whether that's lived experience or professional experience, together to make this happen. 2 years sort of seems like a long time for a project. And in fact, it has flown by because there was so much work to do. And we couldn't have done any of it without all of the people who participated. And that includes our community here as well. So our PCORI Engagement Award is titled Aspire Alliance for Stakeholders of Preeclampsia to Inform Research Efforts. And we are going to talk to you about what is PCOR and SIR. We're building capacity within our organization here. So we're super excited. I wanted to briefly cover what preeclampsia does, who we are, for those of you who may be newer to our community, or maybe you only partake in certain parts of our community, most notably our patient support group. That is our primary program led by Jennifer Heiniger here, who is on screen. But I wanted to tell you a little bit more about everything that we do. We are primarily a patient support and education organization. As most of you know, we are 24/7 in real time providing patient support. We have moderators, all volunteers from all over the globe who are answering your questions, helping you out in the middle of the night or whenever those questions or worries come about. So a big thanks to the highly dedicated volunteers who spend more hours than I know exists in their day to help everyone in this community. You probably have seen plenty of our educational work that we've done, our graphics throughout all our social media channels. We talk about everything from signs and symptoms and risk factors, all the way through the arc of the pregnancy and then long-term health concerns that we have. You're on one of the webinars today, or you'll be watching it at some point. Here are some other webinars we've done in the last year or so. We also do advocacy work and patient advisory work. Advocacy we do a lot of work with the American Cancer Society's Cancer Action Network on biomarker legislation, getting insurance companies and Medicaid to cover the costs of biomarker tests. And biomarker tests are newer to preeclampsia. We've had, in some parts of the world, we've had those tests for a long time. In the US, we've only had the S-split 1 PLGF ratio test available for the last 3 years. And it's still not widely utilized, but part of our work is to push that forward and ensure that when that test is available, the cost would be covered, or at least not out of the realm of affordable for patients like all of us. Advisory work, we work with a number of universities, research institutes, biopharmaceutical companies, biotechnology companies to advance maternal health, particularly as it pertains to hypertensive disorders of pregnancy. So we bring the patient voice, all of your voices, all of our experience to these companies, these universities, these researchers to help them do science better, do technology better in a way that is going to be beneficial for all of us as patients and what is important to us. And that's a bit of the work. We have some crossover in our PCORI and the work we do advising. Here's some of our work with the American Cancer Society. You can go to their website to see what coverage is available in your state for biomarker tests for preeclampsia. And if you are interested in participating in writing letters to your legislators, writing op-eds in newspapers, things like that, that can share your voice locally, please reach out to me. You can message me through the group, or my email is Kara, K-A-R-A, at endpreeclampsia.org. We're always looking for boots on the ground, particularly right now, the work that we're doing in the US to make sure our legislators know that we're here, that we exist, that preeclampsia is a problem, and then that we want access to tests. All right, we'll dig in a little bit more. As I noted, much of what you're going to learn about today, our PCORI Engagement Award, was funded through Patient-Centered Outcomes Research Institute, PCORI, the Eugene Washington PCORI Engagement Award. The content that we're presenting in this report is solely created by the authors of this work, many of whom are on this screen today, and they do not necessarily represent the views of PCORI, its board of governors, or their methodology committee. So this is our work. They were generous enough to fund this work, which is a culmination of so many people. And so what is patient-centered outcomes research and clinical comparative effectiveness research? Katie's going to talk to us a little bit more about this later today. But clinical comparative effectiveness research aims to find out which medical intervention strategies, existing technologies work best for specific patient populations by comparing at least two active existing treatments, oftentimes in real-world settings, to provide evidence for all of the sort of stakeholders, patients, clinicians, policymakers, to make informed health decision and improve care outcomes. These are things that are important to patients. So we're looking to answer questions that are patient-focused, that result in meaningful outcomes to patients, and help create the ability for people to make better health decisions for themselves. We had 6 aims, sort of big topic areas that we set out to cover with our PCORI Engagement Award. The first one was to recruit patients and family or caregivers of patients medical professionals across specialties, researchers, and other affected groups to form our board of directors called Aspire. And then we were going to also recruit a broader network of patients and their families who we call the ambassadors. Some of our Aspire board members are here on the screen today, and our ambassadors will have a small group of our ambassadors who are going to speak to us later today. So they'll be on it and talking about their experience. For Aspire, we have a project team. Now, we have some overlap in this team. This team is also a part of the Aspire board. So just to give you, see their faces and their names and their affiliations. In addition, our other Aspire board patient members, I've bold texted the folks who are patients and also professionals, have a science background. We are really lucky to have such a wonderful group of people who have experience on both sides of our topics here. Some of these folks you're going to either recognize their photos or their names because they talk to you frequently in the group. They've been featured on other webinars. And some of them may be new to you, but we really wanted to call out our Aspire board who've spent much time of their personal time and their professional experience to assist us in our work. I mentioned that we wanted to make sure we were recruiting from a wide area of specialties. So in our group, we have MFMs, we have cardiologists, we have sociologists, medical anthropologists, and even ethicists from our clinical sort of scientific part of the board. And then our patient group is also has a very wide experience from different parts of the world, as do our ambassadors. So we were successful in our first aim. Our second aim was to train those who are participating in the Aspire and Ambassador groups on what is patient-centered outcomes research and what is clinical effectiveness research, as well as some basic primers on preeclampsia, particularly for those who don't study it, as part of their profession. We are going to, like I mentioned, talk to our ambassadors later today from our 2 to 2:30 p.m. Eastern time session. So we hope you can join us for that and hear about our ambassadors who participated in focus groups, surveys, and other ways of giving us input in the training as well. I really wanted to highlight the ambassadors here briefly. We had 150 ambassadors that were selected. We put out a survey inquiring as to who might be interested in participating. And we had our goal was to recruit 75 each of the 2 years. So this current year, 2025, is our second year. And just some of the quotes that we received from some of our ambassadors, I think are important to highlight. Being an ambassador has given me the opportunity to connect, learn, feel less alone. I've gained a deeper understanding of my own experiences, like why my care team moves so quickly to deliver both times. And I hadn't realized that once preeclampsia develops after 34 weeks, immediate delivery often gives the infant a better chance at recovery than waiting for full term. This role, her role as an ambassador, she said, has turned confusion into clarity and fear into empowerment. And I mean, that just makes my heart all warm and tingly inside. We certainly have asked a lot of our ambassadors, and I'm just pleased that we were able to give something back to them as well. All of our ambassadors that participated completed the PCORI training, which was a number of videos on what is patient-centered outcomes and what is clinical comparative effectiveness research. So I had some homework to do as well. I'm a 4-time survivor of preeclampsia who's now living with chronic hypertension. I enjoy being an ambassador because I find solidarity with other survivors and enjoy educating and advocating for preeclampsia research. In addition to prenatal, postpartum mental health counseling, you're going to hear mental health as one of our big topics later on today. I found healing through advocacy work, such as being an ambassador for hypertensive disorders of pregnancy, where I retell my story and connect with other survivors. And that's really what we asked of people, was to share their own personal experiences, their own stories, to help inform research. And that's a big ask. Whenever we share our stories, it comes from a place of bravery. And I know some people share their stories out of, the hopes that other people we will be helped by that, and maybe have a slightly better experience. Our ambassadors came from all of these countries, so we tried to get a broad section of our group. As you know, we are a global organization. We have members in over 100 countries, and we were really grateful that people participated and were willing to participate from different areas of the world. And I think it's important to note that all participants were paid for their participation. We think that this is really important, and we know that not all research opportunities from patients can pay, and depending on what part of the world you're in, it may or may not be part of their normal practice. But we believe that your voice and PCORI believes that the patients should be equal partners in research and the work we're doing. And so it's really important for PCORI and also for us to ensure that the time and talent that our ambassadors and our patient participants provided, that they were compensated for that participation. Check. We check those boxes. Aim 3, focus groups. We conducted focus groups. We had listening sessions, asked some, specific questions of our trained ambassadors and some of our Aspire members as well, in order to identify not only what patients wanted research to focus on. We've developed a research agenda, but also what their preferences were for engaging with researchers in research. Like, how do you want to be approached? What do researchers need to consider when asking you to participate in research? And then we've re-envisioned our website. Some of our focus groups, that was part of what they did, was to help us with our website. We're going to talk about the website later in the day as well. So we conducted those focus groups and really got some great information that informed the rest of our project. From those focus groups and from that information, we created a research agenda to outline what the priorities are for patients and families from our community, those who've had a hypertensive disorder of pregnancy. And I'm going to go over these 5 buckets, I will say, is what we're calling them. We're going to talk about them more in depth later today. But the research agenda, the meat of it, is these 5 buckets. Once we gleaned this information from the focus groups and our board went over it, we posed these topics out to our full community, all 60,000 plus members, and said, these are the topic areas that came up. Tell us which one is in which order. Are these the most important to you? Can you prioritize for you what of these 5 topics are, what's their order of importance? And we had a great deal of input on that. And I'm going to give these to you in order. Our very first most important topic that you guys identified and prioritized was screening, initial screening for hypertensive disorders of pregnancy, risk factors, prevention, and treatment. So, what we heard a lot was that you didn't feel like you received a timely diagnosis, or you were not referred to a high risk doctor soon enough in order to receive either a diagnosis or appropriate treatment. And that obviously there are very few treatments and management options available. So you guys noted that we need more effective screening, more effective prevention and treatments, and a better understanding of the causes of hypertensive disorders of pregnancy. And in whether any of those are modifiable, what is prevention? Are there prevention opportunities? Um, and so we're going to talk about this in more detail, but I couldn't agree more with this one really being the most important. I'm not surprised by this result at all. And I think this is really where precision medicine or a scientific approach to determining risk factors, to determine diagnosis is so important. And it's why we do the work we do with some of the scientific community, not only for the research, but those products like tests, blood tests, and things like that that can help um, identify preeclampsia, because it- what we've been doing, or what the community has been doing, isn't working, right? We have an increase in preeclampsia, HELLP syndrome, particularly severe disease. And so when a clinician looks at you and they look at your history and they try to, predict from that whether you are at risk or not, is what we've had for many decades, and it's not precise enough. A lot of us are slipping through the cracks, and preeclampsia is increasing, so we have to do better. Education around hypertensive disorders of pregnancy. Patients identified that some care providers lack knowledge of the symptoms. And a lot of our patients also weren't aware of the symptoms. They didn't feel educated enough to understand what could be concerning. And, we know in part that's because a lot of normal pregnancy symptoms are very much similar to preeclampsia symptoms. So figuring out what is normal and what is not normal. But they felt that they were maybe prescribed low-dose aspirin, but didn't understand it, or weren't prescribed low-dose aspirin. They didn't receive a timely diagnosis. They didn't receive sufficient education. And so we're going to talk about what areas we think we can improve on with education. In third place came mental health, and mental health is obviously extremely important. And so just because it's in third place doesn't mean it's not important. It's extremely important, and it's one of our hot topics in our group. Somewhere around 85% of us walk away from these traumatic pregnancies with some sort of mental health concerns. So trauma, anxiety, PTSD, feelings of guilt or shame, and confusion about what happened. So this is a huge issue for our community, and we want to talk a little bit more about what can be done to minimize the mental health aspects, or provide more support for mental health. Lack of continuity of care. So many of us, we get to our 6-week appointment. We're told to move on to our primary care doctor. And then we got to our primary care doctor and they don't know preeclampsia. They don't understand what we've been through necessarily. They don't understand what kind of care we need going forward, or the long-term effects that are still sort of being discovered, and how to manage those. So we know that's a big problem from our support group. We have lots of questions on, who should be prescribing blood pressure medications. What should our blood pressure be? When should it be at a certain, what should we have cardiovascular screening post delivery? What does all of that look like? So that's a big problem. We'll talk about potential areas of study later. And then our fifth bucket, a topic here, is communication challenges. And I think this is one where if you go back and look at any of the other previous four, you'll see an overlap of communication challenges. Patients don't feel like they're communicated to effectively. And we know our clinicians have 10 minutes, 15 minutes maybe to spend with us. And so this is not necessarily a gripe on the physicians, but oftentimes the system. There's big systematic challenges that affect communication. And yet we need to get better at this. We did some research into our group about aspirin and why there was maybe hesitancy taking aspirin. We did that work with the University of Iowa. And we had such great insights as to why people don't take aspirin, and a lot of those challenges have to do with lack of communication about why they're taking, what it's for, when they should take it, whether or not it's safe. And those are often questions that aren't answered when that prescription for aspirin is given for those people who do in fact receive aspirin as a preventative for preeclampsia. But then many other communication challenges surround preeclampsia in our healthcare, not only while pregnant, but postpartum and sort of lifelong as well. So we're going to talk a little bit more about this communication challenges. But that's the really exciting part here, is that we did come up with these five topics for of areas of concern and most importance to our community. So we're going to talk about a lot of this later today. We have some short-term, medium-term, and long-term outcomes, and we have pretty much gotten through all of our short-term outcomes. We are going to announce later today expanding our Aspire membership, our patient advisory board creation. And we've also started reaching some of our long-term outcomes, even though our award is just wrapping up here this December. We've already written some grant proposals with universities that have an overlap or an aim of patient engagement particularly with preeclampsia research. And we're also working with some young investigators through a K-12 scholarship to help really mentor young scientists on how to engage with patients in research. So we're really excited for that and all that is to come. We're going to talk more about AIM 5 and AIM 6 in our later sessions today. All right. Let's see, I can't see. Hold on, I just have to do a couple things here. Oh, good. I think we have everybody on now. So we're going to transition to our next session. I'm sure you're all tired of listening to me already, and it's a long day. And I apologize, I have a little cold. So I'd like to introduce a couple of our Aspire board members to chat today with us about their experience with the board, but also, their thoughts on where we can go with research based on the work that we've done. So I'm going to just kind of call on each of them so they can introduce themselves before we get started in our talk here today. Katie, we'll start with you.
Hi, everyone. I'm Katie Corcoran. I am a
Oh,
professor.
I can't hear you.
You
Can
can't hear
anyone hear her? Oh,
you?
maybe it's me. Sorry. Go ahead.
I'm a professor of sociology at West Virginia University, and I study social determinants of health. I am also a gestational hypertension and postpartum preeclampsia survivor, and I found in preeclampsia after my first pregnancy, where I had preeclampsia, and started volunteering and collaborating with and preeclampsia, and that led to this project.
Thank you so much. I will go to Sydney next.
Hi everyone, I'm Sydney Martinez. I'm an associate professor in epidemiology at the University of Oklahoma Health Campus. And as an epidemiologist, I study health conditions across populations. And I got involved with working with Katie on a different PCORI, a different patient-centered research or capacity building project, and was interested in working with her on this project because my mom is a preeclampsia survivor. So I had heard, although I don't have that pregnancy experience myself, I've heard my birth story every year around my birthday. And my, dad tells the story of how he had to walk out of the room and thought he was losing both of us. And so I've heard that consistently throughout my life, and was really excited to be part of this to build capacity and really truly patient-centered work with this project.
Thanks, Sydney. Donna?
Hi, I'm Donna Santillan. I am a professor at the University of Iowa in obstetrics and gynecology. My PhD is in the biomedical sciences and molecular biology. I've known Kara for over 10 years, maybe closer to 15. And so I've worked with her on raising awareness for preeclampsia for a really long time. My research in general focuses on improving women's health in pregnancy. I've just really been appalled my whole adult life and how little we know about pregnancy, considering that everybody comes from a pregnancy. And so after graduate school, I did my postdoctoral studies in perinatal biology and have stayed in that field.
Thanks, Donna. Jennifer.
Hi, I'm Jennifer Heiniger. I am a three-time survivor of preeclampsia. I have a 22-year-old, a 19-year-old, and 16-year-old twins. Um, and I am a peer counselor. I'm the director of education for our support group, and it's my passion to help our other mothers know what's happening to them and help them advocate for themselves.
Thanks, Jennifer. And then I'll go to Danielle and Brenda. Just to note, I didn't put in their affiliations because I know that their work isn't necessarily the work they're doing here isn't necessarily on top of their institution, but you're welcome to share your institution if you want. I'll go with you, Danielle.
Sure. Yeah, I'm Danielle DeVito, and I'm an associate professor at West Virginia University. My research is mostly in the realm of intimate partner violence, but I did have PCORI funding and had an engagement award to do work in that area. And so I'm at the same university as Katie, and I think I must, it's been a while now, but I came across her project and reached out and told her that I would be interested in talking with her about not only the PCORI funding, but the topic, because I did have preeclampsia with my first pregnancy. And so we ended up meeting and talking about the project. And then I was invited to come on board as, a board member. And that was just, it's been a really good experience diving into not only the research on this topic, but also just hearing other people's experiences and really seeing how much further we really do have to go in this area.
Thanks, Danielle. And that leaves last but not least, Brenda.
Yes. So I'm Brenda Paperniak, and I am a NICU psychologist and a perinatal psychologist. I work with Nationwide Children's Hospital in Columbus, Ohio, and then I'm also a clinical assistant professor with The Ohio State University. And my focus in my career has been perinatal mental health and working with moms, and I also was a preeclampsia and HELP syndrome survivor with my pregnancy. So come to this work because of that in many ways. So
Thank you for that. Yeah, we this is a really special group with the professional experience and the sort of preeclampsia experience, preeclampsia adjacent, if nothing else. So I appreciate all of you today. I'm going to actually turn off my slide so we can just see your faces. If I can figure out how to do that, stop share. Nope, that didn't do it. Brr. There we go. I have to get back to the right part of the screen. All right. So can you, and this is just conversational, open to short anyone who wants to speak on it. Can you kind of just for our audience who is really just hearing about this work that we're doing, kind of talk about what we did here is not technically research. We did a lot of qualitative work to help inform research. But as either professional in this business or a survivor or preeclampsia adjacent, what was different about the work we did here versus maybe an NIH funded research? Kind of talk about, maybe Katie, you want to talk about CER?
Yeah, so I can start with CER. So as a reminder, comparative clinical effectiveness research is when we compare two or more interventions, which could be medications or procedures or programs that have already been shown to work. And typically they've been shown to work, but not always necessarily in a real world context. And so CER research is when we take those interventions, whatever they are, and we compare them in real world contexts with real people, with typically without very many exclusion criteria. So with as many people, as diverse people as possible. Patient-centered CER is when the patients are really driving the research questions, and they sort of participate both in coming up with the research questions as well as helping with designing the research, designing the recruitment materials, helping provide feedback on results, and helping with dissemination. And so I think the main driving factor of this project was through engaging with patients that are part of preeclampsia and realizing that many of the questions they have, there isn't research on, right? And so, we go to find research and we can't find research because like their questions are not being directly answered, right? And so we can't always provide them with the information, or couldn't always provide them with the exact types of information that they wanted because there has not yet been research on it. And so because of that, what we wanted to sort of do was create a research agenda based on patient concerns and based on patient experiences and stories. And so I think that's what we did, right? We engaged patients, we trained them so they understood what CER is, what research is, and their role in the research process. And then we engaged them to learn about their stories, and then to take their stories and sort of develop them into questions. And so I think that is what is different from in many ways from NIH, because the focus is not on researchers coming up with questions. The focus is on patients coming up with questions, and then in collaboration with professionals, right? Many of whom are here right now, sort of refining the questions so that, you know, they can be sort of tested, right, empirically, but always in collaboration and in partnership with the patient population. Did I answer the question, or did I go?
110%. Yeah. I'm not sure my question was good to start with. So I'm glad that you got there for me. I appreciate that. What can researchers take away from the work that our patients have done here, to utilize it in the future studies?
I can go.
Great.
I think it's really useful in helping to design our research, because just because we think that an outcome might be important or a question might be important, it doesn't mean that it's important to the community of people who have this lived experience. And so there's no sense in doing work that's not important to the group that it's going to affect, right? And so we all want to use research dollars most effectively. We want to answer questions to the best way we can. And you also, because patients are often involved in research, you want to design research that they're going to want to be a part of, and to ask questions in a way that they're going to be willing to respond to and not react negatively to. And so sometimes things like, there are simple questions that you might ask, like, how many times have you been pregnant? And that might be offensive to some people, and to different populations based on their past experience. And to some people, it's just the normal way a question gets asked, and they give no second thought to it. But to other people, people who've experienced a stillbirth, they might not know how to count their kids and feel like they're not honoring the kids who are not still alive. But to other people, they find it offensive because they think you're asking if you have a lot of partners, when that's not the point of the question, and or why you're asking, like it's just a nosy question and if there's a reason to it. And so it also helps let us know how to come at the research and how to ask questions, but to ask questions in a way that's more respectful of the people that's involved.
Yeah, that was perfect, Donna. Thank you. This really, this work has, I think, helps us as an organization. We're an all volunteer organization, meaning there's nobody's getting paid to do this work, right? It's all a passion project for all of us. And because we have such a large community all over the world, we get quite a few requests from researchers to advertise their studies, to recruit patients for their studies from within our group. And so some of the, concerns we've had as an organization, where, we review these first and foremost, our members' safety is most important. And so we want to make sure that any recruiting for studies it has been cleared through an IRB, an institutional review board, to make sure that it's a safe, so professionals have looked at it and deemed it good, safe for participants. And yet our standards as an organization may be higher than whatever the IRB has approved. And then sometimes we get the questions from the surveys that the researchers are wanting to post and recruit our patients to answer. And maybe they don't actually align with what they told the IRB they were going to ask. Or the questions they're asking aren't going to get them the answers that will best inform their work, right? So we can see from our lens, from our perspective, and even ask questions like, what were you hoping to get from this question? Because, this is likely how people will answer it. Is that going to, get you the information you need? Or they're just, to Donna's point, they're not asking the right questions, right? And so, it takes time and effort from our volunteers to review these. And sometimes they're perfectly safe, but they're not going to be good research necessarily. Sometimes they don't align with their IRB. And so, part of this work is really, asking our patients, and we're going to talk more about the preferred practices plan, which is really one of the questions we asked our ambassadors to answer. How would you like researchers to engage with you? That's going to help us as an organization ensure that we're getting, research opportunities to our community that are going to feel safe for them as well in how they ask the questions and what questions are they asking. And so some of this work has, will help us as an organization, as well as hopefully help researchers do better research and help patients, want to engage more in research because it feels good, it feels safe, right? Even if that's just answering questions in a survey, sometimes those can be very triggering, to Donna's point. Why should patients consider participating in research? And why is it important that they do? Anyone want to take that one?
As a researcher, often asking other patients to, or patients to participate in research, I think it's important for, stories are very powerful and can help, other people understand, problems and things that are happening in practice. However, data clinicians and health systems want data-driven decisions. And so helping, research is a way that we can kind of collect those stories in a meaningful way. Patient-centered research helps make sure that the data that we're collecting, is important and meaningful to what patients need. But also, really statistics and kind of quantifying those experiences across patients is really helpful for making clinical changes. And so that's why I think it's helpful for patients to try and participate in research when they're able to and when they are comfortable participating. I know that, a lot of times right immediately after an experience is really hard for you to be ready to participate. But kind of when you're ready, that's why it's really helpful for us to be able to quantify those stories across populations.
And I would add to that, as somebody who hears these stories daily in the NICU population and seeing families, I think being able to engage our families in the research directly is actually helps with the trauma, right? So many times patients, I hear it over and over, do not feel like they were a part of the process or that they were heard or listened to from their medical teams. And so I think it is important for us to listen to what their experiences were and their stories to help guide. This isn't a hypothetical for our patients, right? And so I think that's the other thing is we need to understand that this is the life that so many of our patients and all of the patients that we're working with experienced. And so I think having that awareness is trauma informed in that way that we ask that and work with that.
To jump in as a patient who has participated in research, I found it very rewarding. I found it helpful to process my own trauma. And now that my children are reaching adulthood and like the possibility of grandchildren isn't hypothetical anymore, it's like on the horizon, I definitely want to push the research forward for the sake of my own children and grandchildren when the time comes.
That's an interesting perspective, Jennifer. I know I have this is not necessarily like a good reason to participate in research, but I have like survivor's guilt, and so that drives some of the work that I do, and participation in research, because while my experience was just as traumatic as anyone else's, um, ultimately, right, I'm still standing. My daughter is here, and well, and we particularly, I feel, had quite a bit of privilege in the care that we received, where we happened to live, the insurance we had, where we live in the world, so many reasons, the color of my skin, right, all privilege. And so we had good outcomes, and I know so many people don't for any of those reasons, right? And and so I feel like it's a way for me to give back, and help somebody in the future hopefully have a better experience, whatever that may be. Um, there's different types of research, right? So, and probably Donna can probably talk in more depth about that, but there's research that's just answering surveys, right? There is research that is, going in and having your blood pressure taken or having some blood taken. Donna has a really big biobank where they collect blood and tissue and samples, in order to do research, and then then do research with other universities and things like that. And then there's research where you're maybe actually taking a medication, a new therapy or something like that, and there's healthy participant, safety, sort of safety studies, and then actual sort of treatment. Does this work? I know Dr. Majid Constantine, who is on our Aspire board, he's got a PCORI grant right now, a CER grant, looking at different dosages of aspirin, which is a hot topic in our community. Should it be 81 milligrams? Should it be 162 milligrams? Adjust if you're in a different part of the world, and Europe has different the doses and things like that. So there's different types of research, and so depending on somebody's comfort level, they could participate in research, such as participating in studies, or sometimes you can donate your placenta, right? That is a way to participate in research. Um, how can patients find research to participate in other than when we post opportunities? Where do you think, where can you tell me where patients can find research opportunities? They're seeking out an opportunity.
I mean, we have them posted on websites at our university, and so I would say to look at the websites for your nearest medical centers. Unfortunately, they're usually centered at academic medical centers, so if you have those would be probably the most bang for your buck there. And we do some advertising in the community, so I think look around. Sometimes there's direct mailings that you might get where they come from the hospital if you tell them what your criteria are of the people you need, and so it's sometimes people get weirded out by those letters that you could get at home saying you might qualify for this. It's not lots of people going through your medical record. They are sent out without telling the researchers who you are, and it doesn't violate HIPAA at all. But you could respond to those, because that is we get very low yield from those, but that's our best way to reach out to people without knowing who they are. We also ask patients, as you mentioned, we have the biobank, when they're joining the biobank, if they want to participate in a registry so that they can be contacted for future studies. And so if you are already part of a study and they ask you if you want to be contacted for other studies, that's another way to kind of stay on the radar of the researchers that are going on. And you're right, research is a spectrum. And so there's all different kinds that you can do. You could be just giving samples. And so that could be done, and our samples come from the same time you're getting a blood draw for a clinically indicated sample. So it's not extra needle pokes. It's super easy for people. Or from the group, I saw that people were concerned about how their blood pressure is taken when they're in labor and delivery. And if they're laying down, does that one actually count because now it's lower? Or is it because their blood pressure is lower and it's being taken the right way? And so we did a whole project on that, and the recruited people came in and we took their blood pressure in all different ways. So you can find projects that, will work with your comfort level of how much or how little you want to be involved in different projects.
Yeah, and some electronic health records have the option of like checking something. Like I just actually was asked in my health records if I'd be willing to be contacted about research studies. And so I think that's, in some of them, it allows you to check that box that you can be contacted for future research studies.
I think checking with your own physicians about what might be going on in their hospital or institution is probably a good way. to get involved. And then what is it? Clinicaltrials.gov. Clinicaltrials.gov is also, you can go in and look for sort of your state or area to see what sort of trials are going on. And there's lots of research out there, not, that can be useful and beneficial, that's not necessarily like preeclampsia specific. I know there's the million person study, and some other ones. So there's active opportunities to participate in research. And I think of note is there's a lot of preeclampsia research ongoing, like all the time. The work we're doing here is to really engage patients and what patients want, patients' voices in what they want researched, and also, what their preferences are for, potentially participating in that research. And so I think that's a different angle than then I think then a lot of research we're not really trained to to give consideration to that patient voice. So it's part of the work we do is talking to particularly younger, new, early career investigators, and helping them and get engaged in with patients in the patient voice. Donna has me to one of her classes every year to kind of talk to her students about patient engagement. So Carrie Haverty wrote, speaking from perspective of an organization working on developing new technology for preeclampsia prediction, Mirvi, she works for Mirvi. You can also sign up for updates on their website, and probably other companies, and occasionally receive communications about research and future research opportunities. That's great. Thank you. Thank you, Carrie. Great. All right. Thank you all so much for joining us today to talk a little bit more about the work that we're doing here, and your participation as professionals and survivors or preeclampsia adjacent, to help the people watching today learn more about what we're doing. We are going to go now to a break. Wait, are we on break time? Yes, we're going to do a break for about 15 minutes, and then we will be back to talk about in a little bit more in depth about the problems that we've identified, and what research can perhaps come from that work. So we'll see you back. Feel free to stay logged in. You can just turn off your cameras if you want. We'll be back in 10 or 15 minutes. Thanks. Our last session went over a couple of minutes, so we will give people a few minutes to get back on the Zoom, and we will then talk a little bit more in depth about each of those 5 topic areas that our ambassador and aspire groups uncovered as their top priorities for research. Talk about the problems a little bit more in depth, and what are some research questions that can be answered by doing some research around these topic areas. Please let us know where you are watching from today. You can post in the group or in the chat here. If you're watching this later today, we would love for you to let us know later today. You can post in the recordings where you are, where you're at in the world, where you're watching. Share any feedback you have about the work we've been doing, and ask questions. We will come back and go through those questions and try to give you some answers or to take into consideration your feedback in the work that we're doing. Hi, Jennifer. It's just us. They left the patient advocates to answer the research questions. It could be an interesting session. Can you see my screen okay? Great. That was a quick break. Sorry about that, Katie. We went over the last session, but it was good. I built in a 15-minute buffer time, so we have a little extra time to have in. All right. So that was a great session just about the work that our ambassador and aspire groups have been doing. And of most interest are these 5 topic areas of that our members have indicated are the most important for in their lived experience and in their current world. What's most important to them to see researchers take a look at. So this first one is again was rated the most important topic of our 5 topics, and I think like I said earlier, it makes me very happy that that this was the consensus because we've known for a long time that it's really difficult for someone to look at a human and and look at their history. For many of us, there was no history. We hadn't been pregnant before, right? That risk factor, that first pregnancy risk factor, is a pretty big one. And make some sort of prediction about whether we were low risk, high risk, and certainly there are conditions, pre-existing conditions that can sort of automatically put someone into a high risk category. And for many of us, sometimes those high risk conditions really are uncovered by the pregnancy, right? We didn't have a kidney issue before. We didn't know that we had a genetic predisposition to chronic hypertension until the strain that pregnancy puts on the body sort of highlights those potential issues. So and clearly with our rates of preeclampsia increasing by, I believe, 25% in the last 10 years, and much of that increase is in severe disease, preterm severe disease. What we've been doing is not working, right? Jennifer, who spends I don't know, like 80 hours a week answering people's questions in the Facebook group, can probably speak to that the most in the all of our, it was like, my pregnancy was totally normal until it was not. That's the point we need to, we want to try to get to. Can we figure that out before things blow up, before that pregnancy it starts going in the wrong direction? And obviously we do a lot of work and have been strong promoters of biomarker testing, the SFLT1 PLGF test. Thermo Fisher Scientific got FDA clearance of their SFLT1. And I see I have a little typo in the text here. SFLT1 PLGF ratio test, which is biomarkers. It's two biomarkers and how they relate to each other. It's been available for 3 years now, and almost 3 years, two and change, and it's still not being widely used. But we talk about this whenever we see one of our members come along and they're like, well, they're not sure what's going on with me. But we're big proponents of this sort of precision medicine, trying to figure out risk stratification. Is somebody truly low risk and they can go forward in this pregnancy and and have low risk care? They can see a midwife. They don't need to have extra testing, or do we need to keep an eye on them because they do have high risk factors, or they could be at risk? And that's, I think, really that gray area. We really don't know how, unless they have an obvious underlying condition, we don't really necessarily know where to put them. And so we're kind of all treated as low risk until and unless we become high risk. And I think most of us who've been in that position, I was one of them, would prefer to figure out, can we tell before things get bad, and then take precautions to ensure I'm receiving the best kind of care. So the problems identified by our focus groups and our boards is not patients reporting a feeling as though they did not receive a timely diagnosis. They were not referred to high risk care soon enough. There were few treatment or management options. Patients indicated the need for more effective screening, prevention, and treatment for hypertensive disorders of pregnancy, and a better understanding of the causes of them, with a focus on anything that could be modifiable, could be changeable, could change the direction in either the type of care or treatment or reduction of disease. One patient noted reluctance to turn to the hospital for postpartum hypertension because their baby would not be allowed to stay with them. We had a conversation about this today, actually, in the moderators group for one of our members who is in that very predicament. Okay, well, my blood pressure is really high, and I'm at home now, and I have my infant here with me. And if I go back to the hospital, most of the time, those infants aren't patients. They're not, there's no one there to take care of them. And if mom is ill, mom, per hospital policy, isn't going to be able to take care of this infant if she has to go on magnesium sulfate or something like that. If there's not another adult who's able, whether that's the other parent or family member or friend of the patient, the mother, they have to potentially leave baby at home, right? Which has all kinds of impacts: breastfeeding, pumping, bonding. And then do they have someone at home to care for that infant, right? They're like, okay, well, I'm on maternity leave, whatever that might look like for them. Is there somebody else here who can take care of the baby and or my other children while I, go back to the hospital? So those are just sort of a few of the problems. So during our strategic planning meetings, we've talked in depth about how can we look at this? How can research look at these problems? What questions can we ask? And can we make some proposals about what to do? So patient-centered CER, clinical comparative effectiveness research questions. What practices are most effective for screening, prevention, and treatment of hypertensive disorders of pregnancy? What is the comparative clinical effectiveness of biomarker tests? We've got the Thermo Fisher, which is called Preeclampsia, the SFLT1 PLGF test. That test can be used right now, sort of per the FDA, if a person pregnant person has symptoms of preeclampsia, but maybe doesn't yet have a diagnosis. They can use that test to get a sense for whether they are, within the next 2 weeks, if they're how likely they are to develop severe symptoms. And so if they're not likely, if they're low risk at developing severe symptoms over the next 2 weeks, they can probably go home, maybe increase monitoring with their regular care provider. But if they test, high enough with this ratio test, then their care providers might say, hey, you're at risk of severe disease. We need to keep you. We need to watch you more closely. And so that helps allocate resources, right? If you don't have to be in the hospital, if you can be managed safely for a week or two, 2 weeks, and then do the test again, well, most of us would rather not be in the hospital, right? It's costly, not just in terms of what it might cost to be in the hospital, particularly for those of us in the U.S. who don't have a nationalized health care. But then there's the other costs, right? Who's going to look after your kids? You've got maybe a job that now you're not working at. If you have a partner, how does that impact the rest of the family dynamic and the sort of unseen costs that accrue there? We have Mirvi's Encompass test that is done, I think, between 18 and 22 weeks. And can risk stratify, tell somebody if they're low risk or high risk, so that they can seek appropriate care, again, kind of allocation of care. And then what, should they be on aspirin? How else can they be managed? We've got the USPSTF high-risk screening guidelines. And the USPSTF guidelines were really meant to cast a wide net to ensure that anyone who could be at risk is treated as such. That's the upside. It's a wide net to try to catch the most people. The downside to that is that now you've got 78, 80% of people who fall in those high risk guidelines. And so is that really helpful to predicting and caring for people who may develop preterm preeclampsia? All right. Katie, do you want to kind of pick up here on our proposed dimensions and our conversations we had about?
Yeah. Sure. I mean, I think just sort of also going off what you were saying, I mean, just keeping in mind that our patients not only care about their own health and the health of their baby, but they also care about their pregnancy and delivery experience, right? And so wanting not only to have better treatment, prevention, management strategies, but also thinking about the ones we have, right? So delivery at 37 weeks, right, for certain sort of presentations or sort of gestational hypertension and preeclampsia without severe features. Think about like more individualized risk profiles, right? Like, is it possible to do more research with any of these tests or others that might help us better predict if it could be safer or okay to have different sort of delivery standards, right? I mean, I think patients care about those things as well, right? So they want to be safe, but they also care about their experience. And so thinking about all of these screening, risk factors, prevention, or treatment, considering both health and also experience and quality of life is meaningful and came up quite frequently in discussions. Let's see, and you talked as well. So the concern with postpartum hypertension, right, and some of the structural barriers in that patients were having to decide whether to go in or not, and whether or not there might be interventions that could be created or that are already being looked at to try to assist with that sort of structural barrier. We also had patients mention that they sort of after our training sort of realized that they probably should have been referred to high risk or MFN sooner. And they really wanted there to be like a standard that says like, if you're high risk or if you're experiencing X, Y, and Z, like you should be referred, because they sort of felt that an MFM or a high risk OBGYN would have sort of understood I guess we'll talk about this next with education, would have understood the symptoms differently than the experience they actually had. And so they thought that trialing different criteria to see which leads to the best outcomes would be something that would be really helpful. They would have found really helpful. Yeah, so I think that would be.
Yeah. And then I think, the UK and Germany seem to do a pretty great job of now you folks in Germany and the UK can argue with me and let me know if I'm wrong here, but in using the biomarker tests, the PLGF or the S-split, they don't use the exact, necessarily this exact same one that's here in the US. Roche has also gotten clearance for a S-split PLGF ratio test, similar to Thermo's, slightly different cutoffs, but essentially the same process. And I think one of my at least personal concerns is that now we've had this available, at least the Thermo Fisher test, since May of 2023, and there's some barriers, some obstacles to its use, and I think this is something that I'd love, to get the patient voice behind more is, why aren't these biomarker tests being, used widely? And we're, as an organization, addressing the potential cost, which we haven't seen. We haven't seen it not be covered yet. I'm sure there are cases where an insurance company has denied it, but it's being packaged sort of under the pregnancy bundle care, and so far it's been covered. It's not nearly as expensive as biomarker tests for certain cancers and things like that, where it's 10 times the cost. It's a lower in general cost. So I think, and then the work we're doing with the American Cancer Society's Cancer Action Network to affect legislation around it. So if suddenly the insurance companies go, oh wait, this is something extra, we are gonna charge for this, we're trying to get that coverage. And yes, we're working with the American Cancer Society. However, the legislation in the US is disease agnostic. So they are championing biomarker coverage regardless of the disease that the test is for. So that's I think that's really important work that they're doing that they don't have to do. they can go and get cancer coverage, and leave the rest of us out. But I think they understand the benefits to biomarkers and the fact that, you know, we're really, learning a lot more about biomarkers and finding new biomarkers and figuring out how they can be useful. But they're still not being used, not even close to widely. It's a very small number of, I think, institutions or clinicians, even not even they're not even full institutions utilizing some of these tests that are available. Mirvi's test is newer, and for a particular, at the moment, at least for a particular set of people who are 35 and older without, any high risk factors. But we have a number of barriers just to access the test that is FDA cleared. Some of it has to do with how exactly the FDA cleared it for its use, which is essentially you're meant to be inpatient. So it kind of depends on how the physician determines whether you are inpatient or not. Some physicians are saying, hey, if you're in the emergency room with symptoms, that's good enough for us. And others are using it, more strictly. But I think that this can do a lot of good in allocating resources effectively, keeping costs down, and allowing for people who don't need to be in the hospital to be home and not accruing those other costs and traumas. It can be traumatic to be in the hospital and also be away from your family and worry about your job and how you're going to pay for things. Um, but also just to ensure those who really are, are they safe to go home, or is that person going to get sent home and they're going to, crash at home? One of our members in our Aspire board went home, and had eclamptic seizures at home, alone in her kitchen for 8 hours. And fortunately, everyone survived and that sort of thing. But can we avoid sending people home who are really, really sick or about to be really, really sick? And so, I think we would love to, as an organization, take some of these screening tests and, use them in combination perhaps with each other, or compare a couple of them to see what might help in delivering, better outcomes, whether that's in NICU stay or morbidity for mother, overall quality of life, these things that are important to our patients. What other points are important about this number one topic here we have of screening and risk factors? We do know that there are some therapies on the horizon. There's a couple of companies that are working on therapeutics. Comanche Biopharma has one that will be testing they've already tested it in healthy non-pregnant human studies. Of course, they did all of the animal safety studies before that, but it will be utilized in pregnant women with preeclampsia in Australia in the coming months. Diamedica is a company that's got a therapy that's in trial currently in pregnant women in South Africa. They're hoping to bring that to the US. So there are some actual therapies coming down the line, at least we're hopeful that they will be safe and effective, and by time help move us forward beyond well, I'm looking at you and you look like you're going to be low risk, so we'll send you with the standard care. but I think there's a lot of questions here. We've made a lot of progress, but we have quite a way to go, particularly with implementation and usage. And some of this is a system-wide error or concern in that, hey, in order to run these tests, you have to have, either you have to send these tests out to a lab that can run them, and that takes time. And a physician may say, hey, instead of sending this test out based on everything I'm seeing in front of me and the years of experience I have, I think it's just best to deliver you. That takes us back to these questions of, is that, the best way? Is that the best outcome for mom? Perhaps. Is it the best outcome for baby? Maybe, maybe not. But those are, I think, questions that can be answered through, taking um, uh, taking this to research, right? Like bringing what we've identified as patient priorities, and then also, and in intertwining that in the research to figure out, what we can do about these barriers to these tests. Any parting comments on our number one topic here? No, but it's clearly a problem. We have we've made some strides. Some of the companies that we partner with have made some strides to these obstacles, and we have a long way to come. I would love for anyone who's listening or will listen later to these recordings to let us know if you received an S-FLT1 PLGF ratio. They may have called it like the preeclampsia test. That kind of tells them over the next 2 weeks whether you're high risk of developing severe symptoms or not. If you've used any other tests like MIRVIS and COMPASS tests, we would love for you to share that with us, and or ask any questions you have about those tests. Now, we would certainly love to see something that we could, figure out pre-pregnancy or in early pregnancy, 8 to 12 weeks, if there's risk factors, so that other, preventions can be perhaps started, and care can be managed appropriately. I think that answers a number of our questions there. Education. This is like Jennifer's area. It's what she spends most of her time doing in our group. We have this overarching motto of the patient-provider partnership. So we educate patients, but we also educate providers. And we educate on, and we're going to talk about communication in the next slide. But a lot of our education has to do with communication. Often the clinician has shared information that they think that has checked the boxes, right? But the patient doesn't necessarily see it as such, or the communication isn't as clear to the patient. And Jennifer, would you be able to talk about our good care? We talk a lot about what is good care.
Yeah. So I think that it's important for people to understand that a lot of times there isn't really anything you can do except evaluate for symptoms and then just wait and watch until things get bad enough to take the next step. And so a lot of times people think that their doctor is neglecting them or isn't paying attention or isn't taking it seriously because they've evaluated, decided you can safely go home, and that's it. Like, why aren't you doing more? So a lot of my job comes down to educating about what is good care, about asking the right questions, about helping patients form questions so they can have that conversation with their doctor. When should we start consider starting meds? When would we consider being hospitalized? What should I watch for at home that would mean I should call or come back in? Of course, there are cases where there is bad care going on, where doctors are not following guidelines. And sometimes I've pulled up countries' guidelines and I'll highlight things and be like, print this out, take it to your doctor, pull it up on your phone and show them and say, how does this apply in my case? You know, it says right here that I'm past 34 weeks, my blood pressure is this level, I should deliver. Why aren't you following this? So, yeah, it's a balance of knowing when it's time to act and when you can safely wait and watch, and finding that understanding of, you know, I feel like I'm not doing enough, but there isn't really anything I can do except keep waiting and watching.
There's such an overlap between education and communication, which is item 3, and not surprising. Well, actually, I think it's number 5. But because a lot of times, you know, the education is happening, but the communication of it isn't. The nuance isn't there, right? Yeah. So, okay. So patients identified that medical care providers and primary care, I think that is a huge one, and that goes to our continuity of care, which is another bucket here. Lack knowledge of symptoms, risk factors, maybe entirely of like HELLP syndrome. And we've often said that the term preeclampsia is not like the best way to describe the disease. Preeclampsia is, you know, essentially before seizure. So we got people who join and they're like, I had postpartum eclampsia, when actually they had postpartum preeclampsia, because there's a confusion of what is it before? Is it before delivery or before seizure? So, and then some people have had HELLP syndrome, but maybe their doctor knew they had HELLP syndrome, but they didn't describe it as such, because we use preeclampsia sort of as the umbrella term. So they didn't maybe understand they had HELLP syndrome until somebody tells them at some point, or they read their records, or maybe the, you know, clinician hasn't seen HELLP syndrome before, right? It's while it's more common in our huge group of people who've been afflicted, you know, it doesn't happen very often in a standard OB, you know, practice. They felt, which they felt explained why they were not prescribed. So if they didn't, you know, understand the risk factors that somebody had or the symptoms, they may not have been prescribed low-dose aspirin, or they didn't receive that diagnosis, and that, you know, those things could have impacted their care, the type of care they got. Reported their partner, spouses, and other parent did not receive sufficient education. Yeah, our partners are often left, you know, and also suffer, by the way, pretty high rates of mental health issues, post-traumatic stress disorder, anxiety, as they're left sort of helpless, you know, like, okay, my partner and my baby are both ill. And we also see from our members, those who are the giving birth, that sometimes their partners don't understand the severity of something. Maybe they have been diagnosed, right? But their partners don't understand the severity of what's going on. There's maybe a lack of education there. What symptoms they should monitor for during and after pregnancy, that postpartum period. There's such a lack of information, and like, oh, you've had a baby, go home, you know, maybe you're on some blood pressure medications. And we have lots of conversations about, you know, blood pressure, what's safe, what's not postpartum, what, you know, medication schedules should look like, you know, how blood pressure medication actually works. It's not like an antibiotic where you take it and then once you're done with the medication, you're done with that bottle, you're good. No, you have to keep taking it to keep, you know, that pressure staying low, because you're taking the medication. If you stop taking the medication, the pressure is likely going to come up. But like, what's too high, what's too low? There's such a gap there in that, what we kind of call our 4th trimester, right? That postpartum period. And then what happens after 6 weeks when things don't go back to normal, which is the case for like half of us, right? The blood pressure doesn't get better like they said it would at 6 weeks postpartum or shortly thereafter. What to expect from your baby if your baby was born early, or maybe your baby was born on time, but you had you still had preeclampsia or help, or your baby still, had some impact of that pregnancy, and then their future risks. Of cardiovascular disease. For those who've had gestational diabetes in pregnancy, there are, future histories of like type 2 diabetes. We're learning more and more about how preeclampsia affects the brain. What does that look like mental health wise, but also, vascularly. And is that going to impact us later in life? Because of the lack of education, they felt unable to effectively advocate for themselves, make informed healthcare decisions. Those are two huge, huge pain points, right? You want to, it's hard to advocate for oneself. And I'm a patient advocate here, by training and by lived experience. And I'm also terrible at advocating for myself, even with all I know. It can be hard to do that. But being able to make autonomous, decisions, make choices, informed choices about what's going on is really important, as humans, but also important in our future mental health, and to just feel like we have such a lack of control, right? When you end up with hypertensive disorder of pregnancy, it can feel like you've lost control of everything. And so then we tend to want to control everything, which we have no control over. And sometimes we don't make the best decisions about what we're trying to control. But part of that is not having that information to be able to make those informed decisions about our healthcare and our babies. The focus groups also identified that the public does not understand hypertensive disorders of pregnancy and provides inaccurate advice based on these misunderstandings. We know it's very complex disorders, and it's more than one, right? We've called it like the flavors of preeclampsia. I think Dr. Mark Santillan, who's on our board, perhaps coined that some years ago. We know it's not all the same disorder. Miravi's data that was published, I believe, in, I don't know if it was Nature or the JAMA publication, showed very distinctive, preterm, 34 weeks and early um, uh, phenotype, and then the term 37 weeks plus. Those are very distinctly biologically different. And then where does HELP syndrome fall? Gestational hypertension is probably preeclampsia light. Not, it's certainly, dangerous, just as dangerous, but it's probably also a flavor or version of preeclampsia. So and then the complexities of gestational hypertension, chronic hypertension. When did that hypertension start? How high is high? And then you get all of the well-meaning, people who are like, stop eating salt, or take this, expensive supplement or vitamin, or try essential oils, or, how about some natural remedies? Because of course we don't want to put anything into our bodies that might hurt us. And so we have to look to the science to go, just because it's natural doesn't mean it's safe or effective. Just because it's, a medication doesn't mean it's unsafe, right? But having that information, and then, the public, again, generally well-meaning relatives or even strangers on the internet trying to be helpful, cause more confusion, and more doubt and more guilt, right? Oh, it's because I ate too much fast food, or I didn't watch my salt intake, or whatever is I didn't have enough protein. Depends on the false cure du jour of the day. So the patient-centered CR questions that we discussed in the strategic planning meetings were: what are the most effective practices for educating patients, clinicians, and the broader public on the risk factors for these pregnancies, symptoms, postpartum care, and risk of recurrence? That's one of our hot topics, right, Jennifer? We get a lot of questions. People find us because they had preeclampsia, and maybe it wasn't, you know, maybe it was term and it was sort of a small blip, but then they're like, wait, I want to have another baby. Is that going to happen again? And or is it going to be worse, right? And the going to communication, which is the fifth bucket here, how that's communicated, how that risk is communicated. And it seems to run the spectrum of, oh, you're young and healthy, and it only happens once and it's no big deal. Or it's the you're at a greater risk because you've had it previously, which people often interpret as I'm going to get it worse, and it's going to be earlier, and neither of those may be true, right? It's so the education piece and the communication piece. What are the most effective practices for educating? We talked about some interesting in education and communication, a lot of overlap there again, from very simple, you know, practices in communicating and educating, and also like a rubber bracelet that says that you've had preeclampsia or HELP or eclampsia, so that if you end up back during the postpartum period, it's sort of a signal to those taking care of you that, oh, this should be a red flag. This person was impacted by preeclampsia, and so we should take a closer look and understand how that preeclampsia may impact what's going on currently, to much more complex options like, how can we get in front of people? How can we share this information? What would that look like if we were providing, education to patients? What does it look like if we're educating clinicians, which I think is the harder group to get in front of? You know, Clinicians who've gone to medical school, who've practiced for many years, and yet things change, right? And then inputs like what we've gathered here from our work. How can we share that with clinicians? You guys have any thoughts on that?
Yeah, I think it goes back to what we were talking about with the previous one as well, the sort of individualized risk profiles, having more sort of education. Like, so they want to know future risks of HCP reoccurrence, but they want to know it for them, right? And so we give them all the data we have, right? So that the average risk, and we can also give them the average risk if they have a particular condition, the average risk if they change their partner, right? But they want to know, like, what's my risk
For
given
me,
that I have this condition and this condition, and I delivered at this time, and I changed partners, and et cetera, right? And they want that information, and we don't have that information because, again,
nobody has that information.
right, nobody has that information, right? But I mean, these are, I think, the types of questions the patients are particularly interested in. Also thinking about when babies delivered at different gestational ages, but also just in general, like babies delivered from preeclamptic pregnancies. What do their outcomes look like? What do they look like based on different factors that happen during the pregnancy, as well as gestational like age? Like, they really want that information. And again, it's more can be more individualized, although general, but they don't really have that information because there are, I mean, and preeclampsia has these like educational materials for low dose aspirin and HCP symptoms and risk factors. Okay? But there's less on these other ones because there's not as much data on it, right? And the patients do very much want to know more about what to expect postpartum, long term for themselves and their babies. And the patients also sort of just talked about different ways of educating, right? Like paper versus we talked about like stickers and magnets and other ways of educating and even creating material specifically for partners. And not just focused on the mom's experience, but also like what is the partner's experience? What should they look out for? What should they do as well? So
very good. Mental health, trauma, anxiety, guilt, shame, and not just from their experience, but it can be, it can be re-traumatized depending on the type of care, the communication, the words that are used when they, are sort of dealing with it and trying to figure out, is this, am I feeling this way because I'm still sick, right? And they may be physically sick, or is this truly, anxiety? Because a lot of times they'll be told, oh, you're just anxious, but then there's no care or plan provided for how to deal with it, anxiety or PTSD or whatever it is. And those are all real, states of illness, right? And so, trying to sort out what is I'm ill from the preeclampsia versus I'm ill from the experience that I've endured. And then whatever sort of stigma that they may have attached to it based on how they grew up, their culture, how their close family and friends sort of understand or deal with mental health. And they often have a lot of distrust from the medical industry because they maybe feel through their experience with preeclampsia that they weren't listened to, right? That from all of the previous bucket, right? They weren't listened to, they weren't diagnosed timely, they weren't heard. And so now they have just, zero trust in going forward. And I think they utilize our support group to gut check, right? They come, they're like, this is what my doctor said. What do you think? Well, me without a medical license thinks that here's the things that we often see, and here's some questions you can ask and ways you can re-engage with your healthcare professional. If you don't trust them, second opinions, like how can we kind of get you through that? They describe being confused regarding what happened. Absolutely. They indicated they or their partner, spouse, other parent lacks sufficient mental health support. Particularly in the US, we don't have enough mental health support workers. Many insurances don't cover mental health care. So there's a lot of barriers. We use Postpartum International is a great mental health organization for those of sort of child, bearing around. You don't have to be postpartum. You could be actually pregnant and still utilize their resources. They have online resources. They have they can make referrals in person for in-person support services. They have sort of mentorship programs and things like that. But it's a really huge concern for our organization, for our membership. And so, the questions are what practices are most effective for improving mental health of patients and their partner, spouses, other parents, et cetera, prenatally, antenatally, and postnatally. And I think a lot of this goes to communication again, that lack of control or lack of understanding is also, cause for, can cause increased mental health, or increased trauma from those experiences. And so where our patient preferences plan is really about engaging with research, but I think there's a lot that we can glean from that as to how patients and their providers can communicate with each other around mental health. But we talked a bit about some different CER options, like could you have group Zoom mental health support, like sessions, like group therapies and things like that? Can you compare them to in-person group mental health support? Can you compare those to one-on-one mental health support? I know those are a couple of the things that we talked about. How can we engage people in mental health support, maybe make it more affordable and more accessible, right? Because, okay, well, now I've been through this thing. I've got a bunch of health stuff going on. I've got a baby that's maybe in NICU, or maybe not, maybe at home. And I also have these mental health issues. And how am I going to manage getting myself and my baby to the doctor, a couple of times a week, plus seek out, therapy that, by the way, my insurance doesn't cover and I can't afford. So kind of talking through like, what are some ways we can make that more accessible for people, and make it maybe more reduce the stigma of it as well. You have every right to walk out of these pregnancies with mental health support needs. There's nothing weak about this. This is this is tough stuff, and it's not a pull up your bootstraps and get on with it. You can pretend to do that, but as someone with personal experience, I did that for the first 8 years until I had my first sort of post-traumatic stress moment where I was like, oh, I need therapy. I should go talk to somebody about that. So lack of continuity of care. We've talked about this quite a bit. Not only, blood pressure medication and, expectations of management of your care after you leave the OB. Sometimes we feel very safe with our obstetrician or MFM, and now we're left to our internist or our primary care provider or GP who's like, yeah, you're fine. Oh, your blood pressure is 138 over, 92. Psh, you're fine. It's fine. We're like, but, what we're reading is that it should be below 119 over 79, 79, or like, I'm having these side effects from this medication that I'm taking 7 or 8 times a day. Can I get to something that is more manageable with the schedule? Like the more times you have to take a medication, the less compliant people are. Just our human nature, right? Life shows up. And do I need to have somebody take a look at my heart? We often say, go have your blood pressure medication managed by cardiologists because there's a specialist. But then that's a whole nother level of mental health concern, right? Oh, cardiologist, I have to go see a cardiologist. Am I gonna die? I feel like an old sick person if I have to go see a specialist. And yet that's probably where we're going to get you should probably get the best blood pressure medication management at the cardiologist. But do you have a cardiologist? Does your insurance pay for a cardiologist? Are you going to have to drive 4 hours to get a cardiologist? Like those are all concerns. So what practices are most effective for increasing continuity of prenatal, postnatal, long-term care? What is the CER for maternal morbidity of postpartum self-monitoring blood pressure versus patients having their blood pressure taken, say, at their infant's well check visits, right? Even in NICU, we've had tons of parents given birth, babies in NICU, The parents home now, the mom's home now. They go in to see, they're not feeling well. They go in and some, uh, angelic NICU nurse is like, why don't you let me take your blood pressure, right? And they go try to find an adult cuff and go, oh, we're sending you back down to the emergency department because your blood pressure is high. Uh, how to handle new or ongoing symptoms. What's the comparative clinical effectiveness for long-term cardiovascular health? Checklists, right? We're also about all the easy things. Can a patient give a checklist to their primary care provider? Right? Can we create the standardized? I think Katie, you mentioned this earlier, like the standardized, like here's a checklist. This is what I've been through. This is what I should. This is the follow-up care I should get to engage in a conversation with that primary care provider. What else? Anything else on? It's a big, it's a big issue, right? And we need to put some research behind it to figure out how we can increase the knowledge of preeclampsia and long-term health, communication, right? They're all just interconnected here to get that continuity of care. We have people who are in their 60s who join the group and go, hey, I just had a cardiac event of some sort, and my doctor mentioned that, I had preeclampsia and maybe this was a risk. And right. And we're talking to them, and had they known early on, perhaps there's some monitoring that could have been done earlier um, to ensure their overall health to not get to that point. And then we've talked in depth on each of these topics about the communication challenges around them. What are the most effective practices for facilitating communication between care providers? Like if you're working with a midwife, but you've been sent up to a consultant for or an OB for additional care, or if you have an OB and an MFM managing your care, which happens frequently. You see your OB for most of your regular appointments, you see the MFM for certain appointments, or if things go the wrong way. And often they get conflicting information from those two providers managing their care, and they tend to feel like they're in the middle of this disagreement between their care providers. So how to move forward in that. And their patients, partners, other parent to increase their understanding of their risk factors, symptoms, and the clinical care the patient is receiving or received. All right. Any questions or thoughts or last minute input on those? Otherwise, we're late for our lunch break. So, no. Yes, we are late for our lunch break. So, we will come back on at we're going to have a short lunch break, but for those of you who need a little more time, feel free to take it. But we will be back, and I'll be starting to talk about our patient preferences in engaging with researchers, engaging patients to participate in research. So we'll talk about that next. And then after that, we're going to hear from some of our ambassadors to tell us about how what their experience was in participating. So we'll see you back in a few minutes. All right. That was a short lunch break. We've had so much interesting information today. I apologize that we went over our lunch break a bit. So whenever you get back, we will be here talking about our preferred practices plan. So our overall project was intended to produce kind of three big things, but the first one was those topics that we've been covering, those 5 buckets. We just asked a lot of questions, and our members, our ambassadors, through surveys, through focus groups, gave us those 5 topics. And then we put those 5 topics out to our full membership for you guys to prioritize them, to tell us which ones were the most important for you. And the overall results, which we had, I think, more than 500 people prioritize those research topics, put them in the order that we just talked through. And so our aim number 4 was creating those research priorities, finding out from all of you what was important, and putting them in order of importance. So that was what we really did in last year, in our first year, 2024, of our 2-year PCORI Engagement Award. And the second sort of big bucket item was our preferred practices plan. So again, utilizing our patient members through surveys and focus groups to determine how should researchers engage patients in research. What are the best practices for that? What are the things that they should consider, take into consideration when approaching somebody who's had a hypertensive disorder of pregnancy, and that they want to involve them in some sort of research. We talked earlier about research takes many forms. It can be surveys, it can be through simple things like blood pressure checks, answering questions about what you do throughout the day or throughout your pregnancy. They can include donating urine, blood, tissue samples, donating your placenta, and they can also include actually being a recipient of a medication or therapy of some sort to test it for safety or efficacy. And so we wanted to really find out, what do you as patients want if you're going to engage with scientists in research? And so that gives us our aim 5 here, creating the preferred practices plan. And our goal, and one of PCORI's goals, is that the work that we do here, that the outputs from that can be used by other organizations, be used by researchers to inform their work. So we want this to be able to be adapted for other diseases, for other research, for other institutions. I mentioned that one of our long-term outcomes or goals was to work with other institutions and researchers to do research, to do other projects. And one that we are working on already is this, they call it a K-12 scholarship. It's a means for a early career scientist to have some bit of funding to work on research projects. And as part of that, I'm personally mentoring a early career scientist in working with patients, in patient engagement, getting patients involved in creating the research questions, in creating the research study that's going to happen. And that scientist's area of expertise is not in maternal health at all. She studies a particular childhood cancer. And so we're already seeing the ability to apply the work we've done here in engaging our patients to determine these preferred practices for working with researchers and applying that to a completely different disease set. So that's really exciting, and just sort of came about through relationships we've made. This is through the University of Iowa. So Dr. Donna and Dr. Mark Santillan, through the work that we've done with them here within Preeclampsia, has then resulted in other relationships within their institution. And now we're able to already utilize the work that all of you have participated in to work in other fields of medicine as well. So that's really exciting. So let's talk about our patient-centered comparative clinical effectiveness research preferred practices plan. It's a lot of words. And really all that to say how you, as members of people who've had and been touched by hypertensive disorders of pregnancy, and that includes preeclampsia, eclampsia, HELLP syndrome, gestational hypertension, chronic hypertension in pregnancy, all of that kind of umbrella. Even if you did not have the hypertension piece of it, as we know some of our eclampsia and HELLP syndrome folks do not have the hypertension piece. That this is all an umbrella for all of those diseases. But how you, if you're going to engage with a researcher in doing research, or how researchers should engage patients who've had a hypertensive disorder in pregnancy, how they should approach them, how they should engage them, how should they work with them, to be cognizant of potential obstacles or concerns or things that might make patients uncomfortable. How can we make patients, people who've experienced these pregnancies, more comfortable in their participation in research? We will be posting the full plan on our website. We have a few tweaks to make to it here and there. So we will be sharing this with all of you, as well as our research agenda. And we're not going to hit everything, but just another note that the report and the work we've done here has been funded through the Patient-Centered Outcomes Research Institute, also known as PCORI, which is the Eugene Washington PCORI Engagement Award, and that the content presented in this report is solely the work of the authors, and does not necessarily represent the views of PCORI, its board of governors, or their methodology committee. So just a reminder there. Hypertensive disorders of pregnancy are a set of medical conditions related to hypertension, usually, that affect pregnant people during or following pregnancy. In the interest of creating a PCORI preferred practices plan to advance knowledge about the treatment of our conditions, and then make recommendations from those of us with lived experiences, and then having treated or researching these conditions. The recommendations are informed by the focus groups, and takes into consideration recommendations of our Aspire board, who again is half patients and half researchers, scientists, physicians, professionals in the area. most of you know exactly what a hypertensive disorder of pregnancy is, so we won't cover that in full. These pregnancies impact 5 to 10% of pregnancies globally. They are a leading cause of maternal mortality. 20% of us experience hypertensive pregnancies, disorders of pregnancy in subsequent pregnancies. And maternal mortality rates for Black pregnant people are 5 times higher, 3 to 5 times higher than white pregnant people. We've seen if you're on social media at all, you've seen several recent TikTok videos and such where Black women were not receiving appropriate care. And that's, just one of the, obstacles that Black women, particularly Black women, face in the United States, at least, with care. So we approached the preferred patient preferences by looking at different stages of research and asking questions of them, because ideally in a perfect research, patient engaged research study, the patients would be involved from before the questions are asked, to Donna's point earlier today. Bring the patients in and let's, I want to do some research. Let's talk to some patients. What do you want to see researched? And so we looked at different stages: the pre-planning stage, actually planning the research, conducting the research, and then disseminating those results of the research. Now, research can take a long, long time. Sometimes it's a couple of years, and sometimes it's, decades, depending on the research. So we'll talk about that a little bit more here. You can scan the QR code if you want to find us online and preeclampsia.org. We'll be visiting our website towards the end of the day here. So again, we had recruited 75 ambassadors for the preferred practices plan that we're talking about here today. This is our 2025 work. We did the research agenda in 2024. We had surveys, we had focus groups, and we asked a lot of questions and brought together all of their thoughts and ideas and feedback. And our focus, our key ideas were building structures and processes for long-term engagement. Not necessarily we're going to ask you to fill out a survey and never talk to you again, but really to create long-term engagement, ensure accessible research processes and results, to have to ensure that participants and patients understand their role in the research process, how their participation may benefit them or others. A lot of times in research, we're not seeing a personal benefit or an immediate benefit. A lot of times this work is going to benefit people in the future, but not necessarily those who are participating in it. And have access to clear information about the study and their rights. Utilize a trauma-informed approach. And I think this is probably what people think of first when they think about, working with a researcher, is how is that going to feel given everything that I've been through? Opening back up, sharing information about myself, my medical condition, what I went through. Researchers should build trust with participants, prioritize their safety and comfort, and have flexible plans for participants and patient advisor engagement. We're big fans here at Preeclampsia about patient advisor work. I would say everyone that's doing research or working on something as a part of these diseases has good intentions. And it's not always communicated as such. And so as patient advisors, we can really be sort of the go-between to help the research, the institution, the company, whoever's working on whoever wants to speak to patients, we can help them with their methodology, with their practices, and you're going to see more about what has come of that with the engagement work that our ambassadors on our Aspire board have done here. Following all of our focus groups and surveys, we had a strategic planning meeting specifically for our preferred practices plan. And so we brought all of the information and feedback from those focus groups to our Aspire board for that group of patients and scientists to help make recommendations and really create the preferred practices plan. Our areas of patient-centered preferred practices are trauma-informed approach to the research, understanding how traumatic experiences related to these conditions, such as the loss of a pregnancy or child, how they affect individuals, adapting the research practices to create psychologically safer, supportive experiences for participants, and really ensuring there's transparency. The researchers' ability to be clear and forthright from the outset about each study, about their motivations and intention for conducting a study, and who may benefit or be impacted by the research. Patient and participant and patient engagement strategies and platforms researchers could use to communicate with research participants and advisors throughout the research study and beyond. Again, creating those platforms that are long-term engagement. We most of the time the studies we see, they come in, they ask for participants, people answer questions, and then we never find out what happens in those studies. And that isn't so satisfying, right? Especially if you've sort of dug deep into your experience and perhaps your trauma to be helpful, and then not really know what that outcome is. Our members really wanted to have continued communication about what they've contributed to. Intentional informed consent. There are required by law, at least in most countries, a informed consent requirement. So meaning that the participant in research is often in a very sort of legal sounding and legal document, are told what it is that they're getting into if they agree to participate, what that looks like. What we want to do is go a step further and say this has to be intentional, not just that you've created a legal form and that I've read the legal form, but that I truly understand what is to be expected of me, what I can expect. So an intentional informed consent process that extends beyond the minimum legal requirements of informed consent to ensure potential participants have a deep and clear understanding of their rights and expectations for involvement in the study. And then researcher conduct, expectations for behavior, approach, and strategies that the researchers will use when doing patient-centered comparative clinical effectiveness research studies. So how those researchers are going to talk to you and approach you and behave. We will often get requests in the group. Somebody will request to join and say, oh, I'm a researcher and I want to, advertise my study. And you guys never see those post publicly because we Jennifer typically responds and says, hey, please email us so that we can talk more about your study. And then that's where we're going to ask them about their IRB approval. We're going to ask them about their protocols. We're going to ask them for, if it's a survey, what their survey is. We want to ensure that it is that the researchers are approaching this in a, in a safe way. Even if they're IRB approved, it doesn't mean that the language that they're using or the questions they're asking are sort of best practice for what our standards are. And some of this work really is to set the standards. We're asking all of you, if we're going to allow a researcher to come in and advertise research, what do you want that to look like as far as how they engage you? And now we'll be able to create sort of a checklist for researchers who want to advertise within our organization, to you guys, all of our members, the minimum sort of requirements that we have, not just what their IRB has, but what we as an organization require to ensure that you're being engaged in all of these preferred ways that you have outlined for us. So how can we how can they take a trauma-informed approach? Action items, increase education and training on a trauma-informed approach. I think that is not necessarily something that is a focus of research studies, college classes, for those who are ultimately going to be doing research. To further define transparency, raise awareness of clinician trauma. So we know our clinicians also have trauma from witnessing some of the events that we've all been through. Train student physicians in trauma-informed approach through case reviews, host listening sessions with patients to understand transparency expectations, educate patients and participants about the need for clinical and research neutrality. The premier challenge, integrating a trauma-informed approach into research projects, healthcare settings, necessitates a culture change within organizations and discipline-specific practices that may not be embraced by healthcare decision makers. So really all this to say, there's many opportunities in helping researchers and physicians practice from a trauma-informed professional perspective, but that it has to be, most of these challenges are system-wide challenges, and in order to do this in a way that touches as many physician scientists as possible, there needs to be larger changes within healthcare systems, and that obviously is a huge challenge. Participant in patient engagement, create research project websites. We thought that was a great way. If oh, here's this research opportunity, let me go to the website and read more about it. Convening an advisory board, having an advisory board for that study, like a patient advisory board. Host community forums, host conversations about what this research, get to know the researcher, understand why the researcher is doing the research, have some more understanding about being able to ask questions about this before deciding whether you're going to participate or not. And promote visual patient summaries, allowing the patient to be able to sort of see what their engagement is going to look like. Is it a telehealth call once a month for a year, or is it a blood draw every 2 weeks? I mean, that would be something you'd want to know. How much engagement is this going to require of me? Intentional informed consent, create study communication plans, be clear about personal health information use, like how is this researcher or the study going to use your information, and what are the risks of the research and the benefits, if any. Usually in research, there's not a benefit to the person in the research. It's typically meant as hopefully we'll find a benefit for the future. And preeclampsia can provide resources like consent scripts and guidance and communication plans for researchers through our website. There's a broad understanding of patient-centered research needs and processes. And I think this is because I think genuinely physicians, nurses, researchers, people who are studying these diseases consider themselves patient advocates, and rightfully so. Most of them really truly are trying to help and do better. But patient-centered doesn't mean just asking one patient a question or saying, oh, well, I know patients because I deal with them all the time. But rather patient-centered research, as Katie talked to us about that earlier, is patients as equal partners in the process, measuring outcomes or creating measurable outcomes that are important to patients, not just what's important to the researcher. So there's a broad misunderstanding of what patient-centered means, and getting that may lead to project funding complications or lack of researcher interest in collaborating with us. So a lot of times they're like, oh yeah, we'd love for you to be our patient advisor. Well, yes, and if we're checking a box to say we talked to some patients, that's not really patient-centered, right? We need our patients to be wholly engaged, or we need whoever they're looking to research to be wholly engaged in the process, in that pre-planning, planning, conducting, and dissemination. That's what patient-centered looks like, not just, yeah, we had some look at this and sign off on it. Researcher conduct, creating self-guided project review process, acknowledging contributions. I think that's really important, that that people are acknowledged for their contribution to the work, and that the research should support patient advocacy and education. Some researchers may not be open to the collaborative process of patient-centered research. Sometimes it's just because they don't really know it or understand it, or it's different to them. They've never done it before, so it can maybe seem like it's a scary process, or they're not sure how their institution is going to handle it. To have their research plans assessed beyond their own internal institutional review board. We get occasionally some pushback. We're like, well, our IRB approved this. Okay, that's fantastic. And we have an extra layer of requirements if you want to. And it's not that it's generally, I mean, researchers do want to, they are interested in this, but it's different, it's new, it's scary. Sometimes we ask for their protocols, we ask, and they're used to sort of keeping that information secret so that they can do their study and not have other people doing sort of the same studies. And so they're a little reluctant to hand that over for us to review. We can't in good conscience put that out to all of our members without ensuring that it's going to be safe from our perspective, from a patient engagement, patient-centered perspective, to read out to all of you. A couple of the patient quotes. Everybody's in different stages of grief, or trauma-informed approach. We didn't just have a pregnancy loss. We lost a baby, and my son was 38 weeks. And if we had known that this was going to happen, we could have been delivered and he would have lived and thrived. And he was a real baby, and he has a name. And I think not forgetting that is really important. I've even had doctors that I see now, when I'm discussing my history, I explain that I had a stillbirth and HELP, and they don't even say that they're sorry for my loss. I think that's really critical to just remember that it's traumatic, even years, almost 20 years out, it's still traumatic for me. I think that's, really sort of the heart of what we're doing here and why we're doing it. Hypertensive disorders of pregnancy generate a lot of emotion, and you might be encountering a very wide range of emotions when talking with these patients. So it should be approached delicately. In the participant and patient engagement section, survivors should be involved at every stage of research, from defining the questions to reviewing the results, to ensure the work is truly reflective of the lived reality. So lots of great quotes in there. On the intentional informed consent, being very clear about what it is they're trying to learn, the researchers, and how they hope it will help in the end. Or, what are they trying to achieve? And also being very clear about what they expect from the participants and what kind of follow-up there will be afterwards, so we know what the outcome is. Let's see. Next steps, conceptualize process for recruiting patients from our community, exploring creative strategies for disseminating the results. So we're going to require that we get those results, and then we're going to share them. And we hope that, the researcher will be able to explain how they're going to share those research results with our audience. Develop and share resources for researchers. We want to help researchers. We are pro-research. We just want to make sure that it's patient-centered and safe. So we are proud supporters of safe, patient-centered research. And we want to help researchers do good research. Promote end preeclampsia as a knowledge hub for patients and researchers, and explore new funding opportunities to support next steps for us. All right. Check. Aim 5. Whew. Thanks for sticking with us to this point. So we've created this preferred practices plan. Again, we will get these things uploaded to our website for you guys to read in full detail, or if you just have insomnia and want to read every detail. I think it's riveting, and I hope that you will too. Next up, we're going to talk about our last aim 6, at the end of our day here. But right now, we are going to talk to a couple of our ambassadors, folks that joined our PCORI project as ambassadors. They completed training, and they may have contributed a little bit differently across the 2 years of our project, but likely either completed surveys, maybe focus groups on different topics. And we're excited to welcome them. I'm going to turn off my, there we go. Turn off the slideshow. We don't need a slide for this because we're just going to be talking here. Let's see. Let me get to my notes. Too many notes. There we go. Perfect. All right. All right. I would like to welcome to our group here today. We've got, let me make sure everybody's on. Is Amber on? Amber may not have made it yet. Jenny, Catherine, Sarah, Heidi also. Everybody, there we are. Great. Thank you so much for joining. It's so exciting to see your faces and meet you. Thanks for joining us today and being not only willing to participate in the work that you did, but also show up on screen today to talk to us. So I'm gonna I'll call out each of you, and if you wouldn't mind, just a little brief introduction, and then we'll go from there. So let's start with Sarah. And I love that I see a little baby head.
You do. She is here. We'll see how she does. So, I'm Sarah. I live in DC. I had my first child in May 2020 and developed postpartum preeclampsia, which wasn't diagnosed until I was nearly 2 weeks postpartum and readmitted. But I delivered her at full term. And then this one here came at 37 weeks through an induction because of my history of preeclampsia. And I already had signs of that. My doctors were divided about whether it was gestational hypertension or preeclampsia with her. But then, sure enough, a few days after she was born, I was readmitted with her. With some very high pressures. And this time around, I also had like elevated liver enzymes. So like some HELP symptoms, but not actually full HELP syndrome.
Thank
Is there
you.
anything else in the intros or am I?
Oh, that's good. Whatever, yeah, whatever you want to share is great. Thank you, Sarah. Let's go to Catherine.
Hello. Yes, I'm in Texas and I have one living child. Uh, I had last year at 36 weeks and with help and under general anesthesia due to the levels that I had. Um, yeah.
Thank you. Thanks for joining us today. Heidi?
Oh, just had to unmute myself. My name is Heidi. I had my son Arthur. He was alive and healthy in 2021, except he was 5 pounds, 7 ounces, so considered small for gestational age. The maternal fetal medicine doctor, when I had my 36-week appointment, said he hadn't grown much since the 34th and was kind of concerned, but I wasn't diagnosed until like a few days before I had to end up giving birth. So it was, you're going to be admitted, you might have this baby today, or we might regulate your blood pressure, send you home. I was sent home twice and wanted to keep the baby in for as long as possible. Like I was first time mom, so scared of birth, right? So it's like I just wanted to keep him in for the 40 weeks and not let him come out any sooner. But yeah. And then had him via C-section at 37 weeks one day because I was induced at 37 weeks and was put to sleep, woken up, had to push, put to sleep again, woke up, had to push. Doctor came in, saw how swollen I was. His recedes were going down or something like that, like his breathing or something. And he was born with the cord wrapped around his neck. He was blue. He wasn't crying, so I didn't know if he was alive. So
Yeah, no trauma there, right? Yeah, thanks. Jen?
Hi there, I'm Jen. I just lost my train of thought. Sorry, I'm in Ohio. Um, I had my son, he was born at 29 and 6, because I got HELP syndrome real fast out of nowhere, honestly. And everything became an emergency really fast. So, he was in the NICU for 2.5 months. He's now 18 months. This was in March of 2024. And we're actually doing really well right now, but this was a lot to go through for sure. So
Thank you. We have one other person who's joining us. She had technical issues, so I just sent her the link. So when she pops on, we'll let her introduce herself. But otherwise, we'll go ahead and get started on a few questions that I have for you guys once I pull them back up here, because my brain does not remember all of the things anymore. But so this is just the questions open to anyone. So feel free, to answer or not. Happy to have multiple people share as well. How did you guys find out about the ambassador program? You can just unmute yourselves and talk
It was Facebook,
in the
the
Facebook,
Preeclampsia Facebook group.
and you just saw the survey and
Yes, and I've been wanting to print off the poster with the effects and put it in all the hospitals in my community, but I haven't. But I want to.
perfect. Yeah, I love that. Great. Did anyone find it elsewhere?
Yeah. For me, it was by email, but I'm pretty sure I got to be on the email list. It was through the Facebook group. Like, it was very much like after my first one, I was in a total tailspin. I'd known nothing about preeclampsia, and the Facebook group was sort of the entryway to like finding out anything about preeclampsia.
Oh, good. Glad to hear the emails find people too. Very good. What made you guys want to apply to join the ambassador program?
I think for me, like after I had my son, I wanted to learn everything about HELP, and specifically HELP because that was what I had. And I just like felt like I wanted to help everyone who had ever had help in the future. And, we were in a situation where we got really lucky that we caught it when we did, because otherwise we wouldn't have made it. And so, and it was something where earlier in the week, I had my 36-week checkup. Everything was good. I even asked her about, maternal mortality, and she was like, it does happen, but it's a very big deal. And I don't see that, happening to you. And then a couple days later, she comes in my room like, oh, and the baby's there and everything. And you're like, oh, this would only happen to you, Catherine. But I think that for me, I was like on the website, like I was like looking for jobs to help people with it. Like I was so motivated after that because I just really wanted to be there for other people. And so if I could contribute in the research in any way, I would want to be able to do that.
Awesome. Thank you for that. Anyone else?
Yes, exactly what Catherine just said. Like she got it spot on.
I think that's why a lot of us volunteer. I know it's why I do all of this too. So
Yeah, and I agree with what they're saying. Going through what we went through, I just wanted to see if we could help find more answers. Really. Yeah.
awesome.
I
Okay.
I would echo all of that. And I think it was also, I joined after I'd had her. And the difference for me, even though I think on paper, her birth and my symptoms were probably worse, just the sort of being prepared for what was coming. It was almost like I was waiting for the other shoe to drop. And when it did, there was almost a slight relief this time around because I was like, okay, I know what we're going to start and I'm going to go back in. There's going to be magnesium. And so I think coming to this, it was with the hope that like, right, research like this and advocacy like this will make that possible, hopefully, for other women too, that you're like, okay, we can get ourselves into hopefully safe hands here.
Yeah. That's a really interesting perspective of, like waiting for the other shoe to drop, like waiting, and then also some kind of feeling a bit relieved when it's a diagnosed, right? Rather than being uncertain about like what's going on or what's going to happen or when is it going to happen, to be like, okay, now I kind of know what to expect. So that's a really interesting and traumatic perspective, and totally true. Very honest perspective.
And
All right, got Amber connected. Thank you. Sorry for the technical troubles. We just kind of got started in the first question. Everyone just kind of did a little intro, so I'll let you intro yourself, Amber.
Hey, so I am from Washington State. I had preeclampsia at 36 weeks with my oldest, and that also developed into HELP syndrome. And then I had gestational hypertension throughout my entire pregnancy with my second, but then I actually got diagnosed with postpartum preeclampsia about 3 days after I had him. There was even a situation where I went to the ER and the doctor that I saw was like, "No, your labs are fine. I don't think it's preeclampsia. Go home." And so I went another 18 hours without care for my preeclampsia, and very, very lucky that I made it in time within 24 hours, and I'm still here. But the whole thing was, confusing, traumatic. There were so many different parts to both of my stories that I just became really passionate about making sure this doesn't happen to anyone else. And that's why I wanted to join the ambassador group.
Thank you for that. It's so interesting how, our stories are all different and yet similar, and our perspectives are different and yet similar, and why we get involved. So thank you for joining. What did you guys think about the training that we asked you to participate in, the CER training, the preeclampsia training? Like, had you, ever done anything like that before? Like, just your thoughts.
I would say for the preeclampsia training, I definitely found it very triggering. However, I felt like it was worthwhile to I was like, I want to do this because I want to be able to make a difference and help people. I also there's stuff in the training that helped me realize that my doctor was wrong. And so I think that there's for people learning more about preeclampsia and help learn learning that, oh, okay, I had all this trauma and now I'm however long postpartum. But then also when I asked all these really intelligent and useful questions at my doctor's appointment, at my follow-up appointment, she didn't give me correct answers, and that's not useful. So I did end up switching doctors, and I had already, before I took the training, I already knew I wanted to switch doctors. I just hadn't done it yet because you have a year before. I wasn't a year postpartum yet, so I still was working on that. But and now I'm with the doctor who delivered my baby, and when I saw her, she did say about the one, the risks of my general health, not regarding pregnancy, but just general health. Like when I had talked to my original OBGYN about it, postpartum, she was like, "Oh no, you're fine." And that's the same thing as "Oh, well, was she also dismissing things before I got the help?" So it kind of sends you into a tailspin. But so that was all a lot very good to learn more about preeclampsia, but it is very triggering to learn about it. And then for the research stuff, I think it was fine as well.
Great, thanks for that perspective too. We'll have more talking sessions about how we can maybe make the preeclampsia training less triggering. I know there's sometimes we can't avoid all of it, but if we can make that gentler, we certainly would want to. Sarah? Did you have, oh, I thought you came off mute. We're gonna.
Oh, sorry, it froze me for a second. Yeah, can you hear me? Okay, great, thank you. The training on hypertensive conditions of pregnancy, for me, I was a little bit further out from it, and I think I'd learned a lot really from the admins, the moderators on the Facebook group. So some of it was stuff I knew. What was newer to me was the patient-centered outcomes research, and that was really interesting to me, and that I think that got me quite inspired and sort of wanting, in future to do more. And the idea of research where it felt like it wasn't just paying lip service to the idea of patients being involved, but genuinely meant it. So that was quite uplifting.
Great. Yeah, we really wanted to make sure that you had that background so you could meaningfully contribute. And yeah, we weren't looking just for surface stuff. We really wanted you to be able to engage meaningfully. So that's great. Anyone else?
Yeah, I always enjoy opportunities to learn more about hypertensive disorders of pregnancy. I feel like doing that training though, I already kind of hyper fixated into that world. So it was all very much like, yep, I got this. This is kind of a refresher for me. But the patient-centered outcomes research training was really, really cool and like really an amazing opportunity and exactly what I'm looking for doing this kind of work, because I would love to be a professional advocate. That's like what I've discovered I'm passionate about right now. And it was like something that I could easily do, that was accessible to me and was provided for me to do. I didn't have to jump through hoops to figure it out. It looks really good on an advocacy resume. Um, and I feel like I was like, this is actually something tangible I can use going forward to give myself more credibility in future endeavors. Because, I'm kind of in this like, do I want to go back to school? Do I want to get into public health kind of area right now? Or do I just kind of want to chase these opportunities until I have a robust enough, resume to like maybe start getting more involved in other ways? But I really appreciated it for that reason.
Let me know if you need a recommendation letter. Happy to write one for you
Thank you so much.
for whatever you're applying for.
I really appreciate it.
How did you guys find it seems like most of you found the support group on Facebook. How did you guys find that? And maybe you just Googled it in Facebook group, but how did you find us to start with?
I
Is it
believe I was just Googling preeclampsia to learn more about it, and the foundation came up. And then I believe on the foundation's page, it had mentioned something about a Facebook group maybe. And so then connected with that. And it was really just wanting to learn more about preeclampsia, because those words were only used maybe twice my entire experience. And looking back on all of the symptoms and, best practices, I wanted to make sure that, if I ever do want to write a letter, kind of explaining what had happened, what could have gone better because of, learning about these best practices, I wanted to make sure that I was really informed. And it just seemed like a really good place to get the most information.
Good, good. Would you guys participate in something like the ambassador program again? And if so, why? And if not so, why?
I'll jump in by saying I feel like it's one of the things that I've been able to contribute to in this realm that is actually, I can say like it's actually making a tangible difference. Like getting to be on, um, like the ambassador groups, meeting with the folks that were trying to get funding for their medication trial was like so incredibly cool. And the fact that like they ended up getting full funding is like something really like tangible. Like, wow, my insight and like my experience helped something actually happen. Um, and so like anytime that there's anything like this, I want to be involved. Because it's one thing to like tell your story and be able to like meet with a community that understands, and it's another thing to like be a part of work that is actively changing, the landscape of the, outlook and treatment of preeclampsia for future people. It's just so cool.
I feel the same way. It's exciting. How about the rest of you? Anyone else? Would you do this again? Would you do the ambassador thing again or something similar?
For me, like I only did the trainings like a few months ago, so it's fairly recent, but I think it feels like it's part of this arc of going from preeclampsia is something that happens to you and you sort of lose trust in your body, and certainly first time around like trust in like healthcare providers, because it was like just brushed off until it was very, very late. And then it feels like, okay, you can flip that around and actually have a bit more agency and hopefully help other people out at the same time. So yes, even if just for purely selfish reasons, of like, it makes me feel a lot better and a lot more sort of like this retroactive sense of like a bit of control over things and a bit of ability to direct things in a more positive direction.
Thank you for that.
Yeah, Sarah said that very well. I would definitely keep participating. But I know for me, the idea of not having any control, and this is the way I can make good out of everything and continue. And I've always felt very validated, very seen with all of this. And I love it just feels like people are actually doing things. So so it's pretty awesome to be involved with it.
It's so interesting that you both kind of talked about like autonomy and control with some of our patient advisory work that we've a couple of years ago started working on with an outside organization. I spent a couple of days in Washington, D.C. at the ethics lab at Georgetown University. And what came from a lot of that work on preeclampsia and patient engagement was that we often felt this complete loss of control and autonomy about what was happening to us, not being able to like make decisions or having enough information to feel like we can make a good decision in bad circumstances, right? You have choices A, B, and C, and none of them are good, right? Which one are you going to pick? So it's interesting to hear that, you guys kind of share that very thing here. Anyone else? You can say bad stuff too. Like if you didn't like something, we're 100% open to the feedback.
Think that, I got into it really wanting to be able to help and all of that. And so I think, I understand from the research part of it of how much like self-determination you want to give the ambassadors to decide whether or not to, join a focus group or something. But like for me, the wording of like you don't have to join the focus group, to me it meant like, oh, okay, like then this isn't the main thing. Like, and also with the training, it sounded like there was all this stuff going on and it hasn't quite been like that. So I didn't really know that if I didn't go to that focus group, then I wouldn't get to help for like months and months and months, right? So I know that it was like worded to like give me autonomy of like, oh, like it's okay if you don't participate, we'll still keep you on the email list. But I didn't really understand. I thought like that this was one of like, because you know how in the research modules they make it sound like you're meeting all the time. And so like to go through that training that was quite rigorous, I was like, I'm doing this so I can help people, but then not knowing like, oh, like this is my opportunity. I have to make one of these panels work or I won't be able to participate in this for a while. I didn't really understand.
That is great feedback, and I really appreciate it. And we can definitely do better on that. And you'll all have additional opportunities to participate. What we're going to talk about after this is that we're developing a patient advisory board, and you will all be invited to join that patient advisory board, which will be an ongoing way for you to inform our organization, not just this project, but our organization and all the other projects that we work on, should you so choose. And we'll give more, details about what that involvement looks like so you can make a choice on that. But thank you for that feedback. That's great. And we will make sure to, be more clear about that in the future, what the actual involvement looks like, frequency and that, because it sounds like you wanted to be more involved. And so we will make sure that you have other opportunities to also be more involved. But yeah, no, I really appreciate that feedback. Anyone else? All right. what was your biggest takeaway from being involved in this work, including, I mean, I don't know if any of you have been on to see the rest of the meeting that we've been on for a few hours, but if you haven't, go back and watch. You can see, I mean, the work you did, even if it felt like not that much, like maybe you felt like, oh, I did one focus group or I wasn't able to make it to the focus group, just your participation in every way has informed huge amounts of strategy and practice plans, and like the amount of information it's already being used in other places for preeclampsia and for a childhood cancer unrelated to preeclampsia. And there's going to be so much work that comes from this, and we will be sure to continue to inform you about what comes of the research that what comes of the work that you've already done. But it's had a massive impact, both for us as an organization, and with the work that we're doing. We've used your patient practices already to advise Comanche Biopharma on a injectable therapeutic that's going to be used, trialed, studied in pregnant women in Australia in a couple of months. So we used your engagement practices already to help them create their materials, that patient education materials, and the materials for patients to know what to expect from joining a study, and that intentional informed consent. Like, we've applied all of that already to actual therapies that are going to be used that will hopefully do some pretty great things for preeclampsia. So even if you feel like you didn't participate that much, we would love to give you more opportunities, and know that the work you've done has had a huge impact already. And I'm indebted to your help, because we can't do this alone. It's been 20 years since I've had preeclampsia, and we need all of your perspectives to make all of this happen. So I really appreciate all of you. What was your sort of biggest takeaway from being involved as an ambassador, or as a part of the training, or however you participated?
I would say probably just really reinforces the fact that patient voices need to be heard for impact to happen, and how powerful it is when we speak up. Which, even that, sometimes I'm like, we're trying to build a system where we don't have to speak up so loud. Like, this is, it should be the other way, where we really know a lot about it. We know how to deal with it. We know how to support women with it. But, right now we're still trying to figure out, it's still taking the sacrifice of survivors to be like, no, you all need to listen to us to be able to, help us in a way that is, you know, really in a way that avoids trauma. Because no matter what, your birth situation is like, if you had preeclampsia, there's going to be at least a drop of a traumatic element to that. So I just think it really reinforced to me how powerful our voices are. And I'm really grateful to be a drop in the pond.
Great. We hope that there'll be much more to come for those who do want to participate. How about anyone else? Not required to speak, but I want to make sure you have the opportunity to talk about your biggest sort of takeaway if you want.
My biggest takeaway, I think, was that my community definitely needs to be educated more on preeclampsia, and I would love for it to be a required course at the medical school, or even a reoccurring continuing education credit for OBGYNs or, all of those people. Like, yeah, and just making things better, I think, for the future. And so these stories start turning into they noticed my symptoms. I got the magnesium, not waited too long. Because looking back, my preeclampsia could have been noticed way before I went to my sister's wedding and was a matron of honor with preeclampsia and probably should have, been receiving help, but I have never had high blood pressure in my life. So I always have low blood pressure. It's never gonna go up. And it was just missed. It was really missed. And I believe that the setup of our hospital and being on a midway team and seeing a different provider each time. And I understand like the continuity of care and all of that piece, but I think there's just a lot of policies that could be shifted with the information that we're getting from all of these patients, and all of these stories are just so important in informing things that can change things in the future.
Thanks for that.
I think one of my takeaways is still, so when I had my first daughter with preeclampsia, I was in grad school, I was doing research, but like sort of more social sciences. And so like I had to go against like not against, but I just like, deal with the institutional review board and all of that. And so it was really, the research part was fascinating to me. But then there's also, as someone who spent a lot of time doing research, like hypertensive disorders of pregnancy, for me, there's still, for all, they're much better understood now than they were. There's still this really annoying sort of fuzziness to it, where my experience second time around was still having, different doctors I see be like, well, I don't know whether like I'd really class this as preeclampsia or if it's more gestational hypertension. And sort of just this like, oh, right, when you actually put it into practice, there's still real fuzziness around it. And so one of my takeaways was like, yeah, that's still something that people are trying to navigate in the research and like in practice. In your experiences, it can be quite jarring to have like one doctor be like, okay, this is preeclampsia, we're going to take it seriously, and then you turn around and another's like, no, you could wait till 39 weeks. Like it's not, so it's, yeah, that was sort of I think the training sort of reflected well that that's still an issue.
And to think they have these S-FLIT PLGF ratio tests they could use that are perfect for deciding, is it preeclampsia? I mean, it doesn't say, yes, this is preeclampsia or this is gestational hypertension, but it will say, are you going to get bad, in the next 2 weeks? Which then helps answer the question, yeah, it's probably preeclampsia. So let's go on this pathway of care. But yeah, that's a good, perfect. There's a lot of fuzziness. I like that terminology, and hopefully we can, our goal will be to have researchers actually pick up some of these priority items that you all have been a part of identifying and prioritizing, and actually study them. It'll be actual research, and from there then we can create a standard of care. We can make additions to the current standard of care, which is very fuzzy, right? Yeah.
Whenever I had my baby, the doctor who delivered him said, oh, these are the lowest platelets I've ever seen. And so I told my family members that, trying to explain my experience. And I had two different family members say, well, I've seen lower platelets in cancer patients. And first of all, I was supposed to be healthy and I don't have cancer. So that's not really comparable. And they were trying to make me feel better, but I felt like the doctor telling me, um, these are the lowest I've seen, it's a concrete thing, like, oh, this is actually bad, and what you're going through is actually hard. And so I think that is so nice in the research that you're able to say like, oh yes, this is like really wonderful. We were able to survive this and be able to contribute to help the science and research.
Yeah, that goes back to that And I know we can't control like well-meaning family members, but when our clinicians are trying to, probably trying to make us feel better, but at the same time not acknowledging our experience, then it feels dismissive, right? And that is a lot of times it's just about being acknowledged. Like, hey, I don't feel right. Will you check this out? Sure. We did this test and that test, and we think you're okay, versus, oh, I'm sure you're fine, you're healthy, and ooh, whatever. But I mean, that is part of that, I think, in part the communication challenges, but the trauma-informed professionalism in there as well. So yeah, that's an important point. All right. Thank you all so much. Not only just for today, but really for today, because I can tell you all of the admins and moderators for the support group, we're all actually introverts. And I'm the least introverted of the introverts, I guess. So I get to do most of the talking. But I so appreciate when somebody's willing to come on screen and talk, especially about an experience that was hard. So I thank you for sharing your voices today and your faces, but also for all the work that you've contributed, and know that we will be reaching out as we form our patient advisory board too. So thank you so much. All right.
Thank you. So nice to meet all of you.
Nice to meet you and see
Thank you.
faces and names. We see everyone across a screen and on an avatar and emojis and emojicons and whatever they're called. So it's nice to see actual people faces. Okay, I'm gonna share my screen again. You all are welcome to stay on. And if you also don't want to stay on, you're welcome to leave. I don't want anyone to feel like they have to stay, but you're welcome to stay. Okay, let's go to our day's almost done, y'all. Let's see. Get to the right thing here. Okay, can you guys see my screen again? Okay, it's got the superheroes, which all of our ambassadors are superheroes. All right, that was I love everyone on the screen, but that was my favorite part of the day, was talking to our ambassadors. So I'm so excited to have met them, like in real life on Zoom. Okay, so aim 5 was creating that preferred practices plan, which we've talked about. Our ambassadors talked about kind of their contributions and being involved in that process, and how we're already using those preferred practices for patient engagement within the work that Preeclampsia does and our patient advisory work, but also for in other sort of disease scenarios and as well. And then our final aim was aim 6, redesigning our website and including basically a section for this work, for research, engaging patients in research, engaging with the research community, whether that's hospitals and research institutions, or industry, as we call them, biopharma, biotech, those industries, in creating the tests, the therapies that are being created currently, or being tested currently, and that hopefully we will have as options for care going forward. So our work, we had a couple focus groups on the website. We will likely have a couple, we might have more focus groups as we finish up. This is, everything is marked green except our aim 6. We are putting the final, more of the final touches on our website, but we, as part of our project, PCORI provided us funding for all the work we've talked about today, but also to engage a website designer. We had focus groups to analyze the website we had and to create a framework for the new website. And we have an initial draft website that's up and live. Not all of the links work yet, and you're going to see much more functionality to it, including taking everything. We have a massive amount of information in our Facebook group that we are going to port over to the website. And we're going to, part of the focus groups was setting up the website in a way that's much more easy for people to find the information that is most applicable to them. We have massive amounts of information, but if you spent time going through all of it, you'd probably have your baby and be a year down the road and still not have gone through everything. So we really wanted to, a lot of the feedback came from our own moderator group who is constantly filtering through all of the resources we have available to try to link that information or provide the right graphic to our members who are asking questions. And so we will pop over to the website here in a minute to kind of take a look at how that's going to be set up on our website. We moved our website to a new host, and we will be launching all of this here over the next few weeks. And of course, we'll be letting you know as that gets launched. We really wanted to focus on having not only more accessible ways for you to find the information that you need, depending on where you are in sort of the arc of pregnancy, pre-pregnancy, you know, risk factors, having an actual diagnosis, postpartum, and then like future life. But we also wanted to create that research place where patients can come to find out what's going on in preeclampsia research, and researchers can come to figure out how to engage with patients to do more research, as well as some of the industry scientific companies that are working on these tests and therapies. Allow for streamlined application when researchers want to advertise their studies within our group, within our membership, including a checklist of requirements based on our research agenda and our preferred practices plan, things that they need to do or adhere to in order to abide by these things, these preferred practices that you guys have set out as being important. It'll be a place for researchers to advertise their clinical trials and other research opportunities. We'll be able to share the latest groundbreaking science going on in our little maternal health sphere, and connect our industry partners and their therapies and technologies, and make that information more accessible to members so they can go and look and see, hey, oh, look at this test or look at this therapy, and have a conversation with their healthcare provider about it to see if those are things that they have access to, or that could be applicable to their particular situation. And then share ways for researchers and industry to uptake our patient advisory and engagement services. So this is just a screenshot of kind of the pathways, the arc of pregnancy on our main page. There's a place for you're at risk, how to, or are you at risk? Learn how to recognize your risk factors, checklists, things like that. If you have a diagnosis, here's the information that you might need if you have a diagnosis that you don't need necessarily if you are just at risk. You've been diagnosed, and now you're postpartum. So what is this postpartum period going to look like? What do you need to watch out for? Maybe you develop preeclampsia or eclampsia or HELLP syndrome in the postpartum period. That might look a little different. And then what about long-term health? Okay, I'm a year out, I'm 2 years out, I'm 10 years out. What is the latest research? What is going on? What do I need to know about my long-term health? And so kind of bucketing those resources in these sort of stages of life. And then we'll have a research section as well, which I'm going to take us to right now. Oh, did it work? Can you see the website? Okay, great. So we have some photos and things that we're still working on changing out. And like I mentioned, not all of the links work yet, but we are up and running. Here are those buckets of information where we will, our website team, our tech team is working to pull over the massive amount of information on our Facebook page and organize it in these different buckets here. And then our research updates will have its own tab. Here you can actually read about our Aspire study, what we've kind of talked about all day, as well as other research that we're working on. Here's some of our previous webinars that we've done. We'll have events and things as well. But you're going to find that we have some of our corporate partners here. You can find, this is the Thermo Fisher Scientific that got the FDA clearance, the first FDA clearance in the US for their biomarker test, their SFLT PLGF ratio. Some of their information here, you can go to their website and read more about it as well. Some work that we've done with Rune, educational video tools, and then connections to our corporate partners that are doing work particularly specifically for preeclampsia. You will also find this is where we will upload our preferred practices plan, our research agenda, and you'll have researchers will have access to sort of that checklist of those engagement practices as we roll those out. So we're really pleased to have this framework up. Like I said, our tech team is working to get all of the information moved over, and you're going to find some new functionality within the website for learning and accessing the resources that we're going to have available to you. So we're very excited about that. And we look forward to taking your feedback about the information that we bring over and how it's stored and your ability to navigate and access the website. So we will continue to take feedback on that. And anything you'd like to see added to the website. We love it when you share articles to stories that are relevant to, hypertensive disorders of pregnancy and things that you think may be important for us to share. If there's research that you're a part of that's going on in your community, we would love to know about that. We would love to potentially share that with our group as well. And just as a note, I like to add this slide to the end of all of my presentations, no matter who I'm talking to. An event had happened upon which it is difficult to speak and impossible to be silent. I think that sums up so well the work that we do at End Preeclampsia and our Facebook support group, the work that all of our ambassadors and our Aspire board members have contributed to you sharing their story or sharing their perspective based on their experience. And it's very brave to talk about, what we've all been through and to use that for such a good purpose. And no one has to do that. And yet, when you're able to talk about it, sometimes it brings healing. And certainly in this case, it is helping others. And I think even members who participate in our support group on Facebook just by contributing, whether it's asking a question or providing a warm response to somebody who's, you know, in crisis. That's still using your story to help somebody else out, and that's what we do around here, is taking our experiences. Mine is you know, 20 years past. Jennifer's a little further than that, but it's still important to us 22 decades later to participate in a way that can help somebody else have a better experience, when it's still maybe a bad experience, but better than it was yesterday, or better than it was 10 years ago or 20 years ago. And if we can do that, we've you know, achieved our goal. So I just like to acknowledge all of the bravery, and thank you to everyone who has participated in this work, and everyone who's watched today or will watch at some point in the future, and your continued support of our organization and our work, and what we are trying to do in the global setting here is help people have a better experience. That's all I have for today. Thank you so much. Bye-bye.